Only mode until the question and answer sessions of the conference. I would like to inform all parties that today's conference is being recorded. If you have any objections, you may disconnect at this time. I would now like to turn the conference over to Mr. David Delacruz. Sir, you may begin.
Thank you. Good morning, everyone. So my name is David Delacruz. I serve as the designated federal official and principal staff for the Secretary's Advisory Committee on Infant Mortality. And in that capacity, I officially call the meeting to order. So before we begin, I think some of us have heard, but you all should know that our acting chairperson, Dr. Ed Ellinger, will not be joining us for this meeting. And Dr. Jarris will give us some more information about that. We remain hopeful for a quick and uneventful recovery, and we will continue to keep him in our thoughts. And we'll update you, obviously, as we hear more about how he is doing. Dr. Paul Jarris, who is also a member of SACIM, accompanied Dr. Ellinger to the ER last night and continues to help out and has agreed to step in and help facilitate today and tomorrow's meeting. So please be patient with us. Have a little extra understanding as we try to adjust the schedule and adjust the agenda and as we try to step into some very large shoes that Dr. Ellinger has left for us. We will make the best of this situation. We'll hear more from Dr. Jarris in just a moment, but first a couple of housekeeping and some background information. Just as a reminder, as we move forward over the next 2 days, that some of our members and colleagues will be joining by phone or webinar. So please use the microphones that are in the room. You have to press the little button, and if it's green, that means you're on. And if it's red, that means you're off. So let's try to make sure that not only that would be helpful to the folks who are joining us remotely, but also for our transcriber and note taker. As the operator stated, we are recording and streaming this meeting by webinar. Hopefully everyone's okay with that. If not, let me know. I'm not sure what we can do about that. But let me also just pause and say thank you for your continued commitment to this work. I understand and want to absolutely acknowledge how busy each of you are and that you have made a commitment in both time and effort, and knowing that these meetings take you away from both your office and your family. And therefore, I remain committed as your designated federal official to ensuring that these meetings are as valuable and as worthwhile as possible. And a review of the agenda and discussions I've had with many of you, I'm confident that we'll have a very good meeting these next couple of days. So this is the third meeting of the current makeup of this committee, with the exception of 2 new members who we will introduce and talk about soon. And before I turn this over to Dr. Jarris, I just want to give you a little bit of context for some of you who may be a little bit new, and specifically about my role as your DFO, but also Dr. Ellinger's, or for the next 2 days, Dr. Jarris's role as the committee's chairperson. So as a designated federal official, I ensure that all of the rules and regulations of the Federal Advisory Committee Act are met. As the principal staff of this committee, I also work closely with Michelle Lowe, who all of you should have heard from, and also our HRSA Associate Administrator for MCH, Dr. Michael Warren, who also serves as the committee's executive secretary. For this meeting, we are happy to welcome Laura Kavanaugh, who serves as our Deputy Associate Administrator for MCH. I also work closely with Julianne DeStefano, who provides services as our contracting officer representative to ensure we have all the logistics. Oh, she is here, Julianne. That we have all the logistic support that we need. And then also, of course, Morgan Pinckney, who many of you have heard from, who serves as our logistics contractor along with her colleagues from LRG. So all of us here are to support you, support the work that you do, to support the work that you will move forward in advising and guiding the Secretary of HHS and the Administrator of HRSA on activities related to infant mortality, women's health, and perinatal health. Meanwhile, the chairperson guides and facilitates the programmatic work of this committee. Dr. Ellinger, in this case Dr. Jarris, will facilitate the meeting and lead the committee to help ensure that you are identifying how you as a committee want to advise the Secretary and Administrator. So with that, unless there's any questions, which I'm happy to take, I will turn it over to Dr. Jarris.
Thank you, David, and I want to join David first and ask for your mercy. I learned at about 2 a.m. I was hoping that Ed was going to be here this morning, but I learned about 2 a.m. he was not going to be here, and so that's when I learned about my new job. And I've been help out where you can. And Lisa, who's been running my life for the last 10 years, is doing such help. Ed developed some chest pain last night, and he had him go down to Georgetown, where he worked up, and they admitted him for further workup and observation. So he was in good condition, active denial, as you know, as you'd expect. And my wife and I beat him up and told him he had to go to the hospital. So he's actually doing quite well, but you know, it's a serious thing, and nobody would welcome something like this. So I'll keep you posted through the day as we check in. But again, I want to welcome you. I know how much I look forward to these meetings, because really getting together with some of the really the best thinkers in the nation around maternal child health, and it's so stimulating. And so I look forward to learning from every one of you. And it's important that, you know, we build a committee that has multiple types of expertise, multiple perspectives, and enter a process of true dialogue to understand where people are coming from given their point of view. And I think it's particularly when people present a point of view that you hadn't thought of, it strikes you as odd that there's a learning opportunity, because that's when often you get behind it, you say, wow, I never looked at it from that point of view before. So I'm also want to say, you know, I appreciate Ed is a very active chair, which is good because he's also pretty organized. I think I've divined most of his slides. But we have made some real progress. And if oh, thank you. Phone hygiene. So thank you, whoever coughed, for not coughing us on the room. But if people could mute when they're not speaking, and if you are a committee member and would like to speak, perhaps you could just, you know, unmute, say your name, unless there's a way on the webinar for someone to raise their hand, and then we'll get back to you as soon as we can, because I know how hard it is to be on the phone, to never know quite, are you interrupting someone or are you not? And we'll keep in mind that you're there and have something to say and call on you. Also, if you're on the phone, please don't put us on hold, because if you put us on hold, we will hear your music. The other thing is, if you pick up another call on a different line on your phone, that will automatically put us on hold, and we will hear your music. So I'm sure your music is lovely, but we all have our own to listen to. So thanks. With that, we'll go through a couple of slides here. And by the way, you've all seen the agenda. We're really fortunate that if we don't get through what we need to, we will take a break when Thomas Engels, the administrator, gets here, because he has a very brief period of time. Unfortunately, fortunately for us, he was able to fit us in. Unfortunately, it's such a brief period of time, we probably won't have time to question and answer with him as much as we'd like to do that. So this section, setting the context. There has been increasing attention, as we all know, both on maternal morbidity and mortality and infant morbidity and mortality. In many ways, unfortunately, because things are going in the wrong direction for us. And we continue among the developed nations to see worsening maternal morbidity and mortality, and really, and as we'll hear from the March of Dimes later, worsening of preterm birth. And I'm sure Dr. Barfield will have a lot for us on that. But again, the White House order, we have gotten through, fortunately successfully. As you all know, that stalled us a little bit. There was the president asked all of the different parts of the administration to look at their standing committees to evaluate whether they should continue, and cut up to 20% of them from the administration. And fortunately, and we'll talk about some of the support, this committee was felt to be so important historically and currently that SACIM has survived that. So thank you all for your participation. Importantly, and I'll go over it in a minute, SACIM has some additions and new aspects to the charter, which I think are very important and will reflect many of the views we all hold, that moms and babies are highly related to each other, and that we need to take a life course event, and we'll go over that language soon. Happy to have two new members who we will ask for them to let us know who they are and then their background soon. That's Stephen Calvin and Carol Lee. So we're very looking forward to learning about you and your interests. Ed did one-on-one discussions with many SACIM members, and I'm not sure if he got to the new members, or perhaps he did. Great. And compiled that, and we'll talk about that a little bit later. But I really appreciate him really talking to all of us and formulating his thoughts for the committee. And then again, we talked about increasing awareness of maternal mortality with some good legislation, some good administration attention. But unfortunately, things are not going in the right direction, as they aren't in so many health areas where we're seeing in life expectancy. So we really have our job to do here. This we did talk about the evaluation, and again, thank you to HRSA, the administrator, and everyone in the administration for seeing the value of this committee. And we also want to thank these different organizations who weighed in and expressed their feelings on the importance of SACIM. So thanks to all of you. The charter, and I think this is very exciting. You know, in so many ways, maternal child health has its different camps. And so many initiatives around improvement are either maternal initiatives or child initiatives, and the two sometimes never meet, which we all know simply doesn't make sense. In the ideal world, we would be following the mom and baby through the system as the focus of the system, as opposed to a system focused on our specialty types or sites of service. But so I'll let you all read this, but what I will stress, though, is what's underlined here. Importance of health status of pregnant women and infants. So pregnant women, that's new for SACIM. Life course, we all know that's absolutely essential, that you don't create a healthy baby or a healthy mom in 9 months. Here's the life course initiative. And then preventing, reducing maternal mortality and severe maternal morbidity. And I think this is so important. Maternal mortality is all too frequent in this country, but it's a difficult thing to do quality improvement around because in any given location it's rare. And so really focusing on maternal morbidity, which is much more frequent, is a great way to go after maternal mortality. We should eliminate all this morbidity, so much of which is preventable. And then this will acknowledge the fact that maternal health impacts infants, justifying really why it should be the work of this committee. And of course, hypertension, malnutrition, substance use disorder, and diabetes. And again, not only does that affect the current baby, but it will affect future pregnancies if we don't, in fact, take care of that mom between her pregnancies and allow her to space her pregnancies appropriately. So I'm very excited about this expansion of our work and acknowledgement about what we know from the science, that really it's a life course event, that you cannot separate the mom and the baby when you're talking about. Any comments or questions on that, or roars of cheers? In terms of SACIM, I believe, David, this group was ordained in September of 2019, this year.
So that's correct. So the charter is renewed for 2 years at a time.
Oh, it's not ordained?
Well.
Oh. Okay, so 2 years, so that we're to 2021. So we have a reasonable period of time in which to really set an agenda here, and put a lot of thought into this, and we'll reflect it very soon. Any questions or comments? And because I really would appreciate, and that's part of your mercy, that you all participate in this conversation. Okay. At this point, perhaps we could go on to introductions then. Go ahead, David.
Let me just ask Morgan, do you know, when were the two people from the community expecting to speak? Now.
Oh, very good. Let's do that.
So that we can.
Excellent. So, you know, we all know that nothing about us without us. You know, the importance of community engagement and understanding of people that are really doing this work on a day-to-day basis in the community. And so Dr. Ellinger did arrange for two community representatives to speak. He did tell me about this in the ER last night, but I wasn't taking notes. So I really have to apologize to people on the phone. I can't give you a proper introduction. We have Letitia Davis and Tanya Hanzi, and I guess Letitia, if you don't mind going first. And again, I apologize for not giving you a proper introduction, but if you would please introduce yourself and give us a brief description of your work, we'd appreciate that. We have Letitia, you also may be muted. And operator, could you check to make sure that she has an open line?
Letitia, if you're on listen only, please press *0 to have your line open.
And also Tanya Hanzi, could you also do that? please let us know when you're live.
Okay, thank you.
Is that Letitia?
No, I don't show Letitia is dialed in.
Okay, Tanya?
Yes.
Oh, great. So Tanya, could you go ahead, please, and introduce yourself and briefly discuss some of your work for the committee so we're aware of it?
Yeah, so my name is Tanya Huntsey. I am an Ojibwe woman. I work with the Minnesota Prison Doula Project now. My background with a doula is I received a doula, a low-cost doula, because I was homeless at the time, and I was pregnant with my youngest child. And, you know, really talk a lot about that, what that doula did for me and my son. I was on 100% bed rest while I was homeless, and really, honestly, she was the only person that was celebrating my pregnancy, celebrating me, celebrating my child, was the only person I had to lean on through that time. It was the only way that I was able to just be able to understand and feel that sacredness of my pregnancy, because I was so overwhelmed with all the other circumstances. And because of that, that pushed me to begin a career in being a doula. And so I now work with the Minnesota Prison Doula Project. We are in 7 facilities, and we support incarcerated birthing people. And we're able to do that through grants and other foundations, some contracts with some of the facilities, but mostly it's private donors that are paying for our services. And we're really the only people that are there through the pregnancy and through the birth for these birthing people. And so we really see intimately that it's an honor. It's the privilege to be able to be there for that family, and to be able to hold space so that birth is sacred still and celebrated, and really afterwards we're the ones that are on the front lines with the birthing person through their postpartum period, and making sure that they have support through that time also.
Fascinating, thank you. Just one quick question. After the birth, the mom and the baby, what happens to the couple, the mom and the baby together, or do they separate?
So usually there's about an average of 36 hours that they're allowed to be with their baby. And after that 36 hours, we come back as the doula for a separation, what's called a separation visit. And that's when the social worker comes in, and they either are bringing the child to a foster home or to family members. And that's usually the last time that the mother would see the baby, at least for a month, because they have to go through the process of being able to be accepted and have visitors, that person on the visiting list, the new baby. And in Minnesota right now, we're working, myself and some other women who are formerly incarcerated are working on a couple different policies and bills to present, working in conjunction with the governor and also the Department of Corrections to end incarceration for pregnant women, so they would be in the community instead of incarcerated.
Incredible, important work, and wow, it also must be challenging emotionally. So thank you for what you do. Any committee members or anyone else in the room on the phone have a question?
Yep. Tanya, Steve Calvin here. I'm a maternal fetal medicine doctor, and I've actually seen some of the moms from the Shakopee facility. And thanks so much for your Minnesota Prison Project is real sort of a shining example. I know that there's also work going on in other states. It's patterned on what you're doing there. So thanks for your work.
Yeah, actually, we have another organization that's in Alabama, the Alabama Prison Project, that is under our organization, and we've been consulting with many other states to replicate the program for their state.
Well, thank you very much. I know you really impacted me with this presentation. I'm sure everyone in the room and on the committee. So thank you very much, and I hope you can listen in.
Yeah, thank you so much.
And Latia, were you able to join? Latia Davis? Okay, Latia's from the Delta Health Alliance. Well, if Latia is there and can't get on, or you join at some other time, then we'll work you into the agenda whenever you or she can join. So thank you. My pleasure now to introduce Mr. Thomas Engels, who is the administrator here at HRSA. Mr. Engels became administrator in November of 2019. Before coming to HRSA, Mr. Engels was Deputy Secretary of the Wisconsin Department of Health Services from 2015 to 2019, and managing more than 6,000 employees and a $12 billion budget. And he championed and oversaw the expansion of the state's capacity to provide mental health services, implementation of a statewide electronic health record system, and a reduction in staff shortages at long-term care facilities. He was a member of the Governor's Task Force on Opioid Abuse and also chaired the Governor's Human Resources Shared Services Executive Committee. Prior to that, Mr. Engels was the Assistant Deputy Secretary at the Wisconsin Department of Safety and Professional Services and Vice President of Public Affairs at the Pharmacy Society of Wisconsin. He also served as a Government Affairs Director for the Wisconsin State Telecommunications, and in the past held public service positions, public position working as Governor Tommy Thompson's Deputy Press Secretary. Mr. Engels, we welcome you here, and thank you for making the time to speak to the committee.
Well, thank you very much, and I appreciate this time this morning. And as you heard, my name is Tom Engels. Thomas is my formal name, but I was called by Tom. And people here at HRSA, that's what they call me. So, and I don't want to go through more of my background. As you've already heard, I came from the state of Wisconsin. I'm a Green Bay Packers fan, so don't hold that against me. But I love my pack. So, but I want to take this opportunity to welcome you. And as you heard, I'm relatively new in the position to be. I was the deputy administrator since April here, but I'm relatively new as now being the actual administrator. And I know there's a couple of new board members here, so I appreciate you being new with me here on this, probably being your first board meeting. But I know there's a lot of experience in this room, and I want you to know how much I appreciate everything that you do and the priorities that you're going to be putting forward, because also HRSA's priorities. I also want to welcome our ex-official federal partners who are here at the table with us, and you provide a great perspective that we all need to hear. The fact that this committee has a new 2-year charter in place is very important for the populations HRSA serves. Not only will you be focusing on reducing infant mortality, but also improving the health status of pregnant women and infants. At HRSA, we work every day to make sure the nation's most vulnerable populations have access to culturally competent and highly quality health care. As we approach the end of calendar year 2019, I want to take just a minute to detail some of the significant impacts of HRSA's programs that we have made over this last year. 28 million people were served by HRSA-funded health centers. Half the people with HIV in America were served by the Ryan White program. An amazing 86%, and that just came out in the last couple, 86% of those who were served at those centers are now virally suppressed, meaning that they have effectively no risk of transmitting the virus to an HIV-negative partner. HRSA has almost 15,000 nationally health service corps and nurse corps clinicians working in the most underserved areas of the nation in exchange for loan repayment and scholarships. The HRSA-funded home visiting program has provided more than 5 million voluntary home visits over the last 7 years. While you will be hearing later this morning from my colleagues in the Maternal and Child Health Bureau, I want to highlight what we have accomplished this year to serve the maternal and child health population. The Healthy Start program was recompeted, and more than $100 million was awarded in grants. Through the State Maternal Health Innovation Awards, HRSA has provided new funding to spark innovation, support maternal health services delivery, and address the high rates of maternal mortality and severe maternal morbidity in the United States. We also awarded we were also awarded funding for the National Resource Center. We provided capacity building assistance to HRSA's maternal health grantees and other stakeholders as they engage in efforts to reduce maternal mortality and severe maternal morbidity. We awarded funding in the for the Alliance for the Innovation of Maternal Health, or AIM, Community Care Services. This is an innovative support development and implementation of non-hospital focused maternal health safety bundles within community-based organizations and outpatient clinical settings across the United States. It will build upon the foundational work of the original existing AIM program and increase its outreach to it by addressing preventable maternal health mortality and severe maternal morbidity among pregnant and postpartum women outside of hospitals and other birthing facilities. In addition to these NCHB programs, HRSA's Federal Office of Rural Health Policy launched the Rural Maternity and Obstetric Management Strategies Program, also known as RMOMS. This program involves specific stakeholders, including rural hospitals, health centers, state Medicaid offices, and Healthy Start and home visiting programs, with the intention of developing sustainable strategies at rural levels. In the coming year, we will continue to take a bigger, more complex effort. HRSA is playing a leading role in the administration's efforts to end the HIV epidemic. We will work with our partners across the department on innovative ways to increase organ donation. And of course, we will be working hard with our grantees on expanding maternal health portfolios. I want to extend our thanks and appreciation for your dedication to this committee and to the nation. As members of this advisory committee, you are important in implementing these policies that are important to HRSA and to the nation. I know that Laura Kavanaugh will be providing you a more in-depth update of the Maternal Health Bureau, but I wanted to take this opportunity to come down and just simply say thanks. You have a very important role. Coming from the state of Wisconsin, I know, for example, Milwaukee, Wisconsin right now has the highest infant mortality rate in the country. And one of the things that we were really working to try to understand is what is going on in Milwaukee. Because we also look to cities like Baltimore that used to have one of the highest infant mortality rates in the country, but they were able to cut it in half. And we wanted to know, from the state of Wisconsin standpoint, what did Baltimore do that we could help and implement in the city of Milwaukee and work with our partners in the city of Milwaukee. But we also know this is an urban and rural issue that's being looked upon across the country. So I really appreciate the work you're doing in this. I know you have a very difficult task ahead of you, but I also know that the knowledge of this committee and the individuals on this committee can meet those challenges. But I also want to, as Laura will tell you, I want to extend whatever resources that we can provide to you, we want to be able to provide them to you. If there's data that you need, we want to be able to provide that data. So we look forward to working with you and offering any services that we can offer to you. And I'll be glad to take any questions you might have of me. Yeah, I think the Packers will beat the Redskins this weekend.
That's not very impressive. So I'll get started. And one of the things I think that's within the purview of the administrator, probably more than anything else, is really to start coordinating across all the different systems. I think there's probably not any part of HRSA that doesn't impact maternal child health, whether that's the health centers or
absolutely
the workforce issue, rural, Head Start. So I guess an ask is that ability to bring all these programs together to magnify the force being applied would be so important.
One of the first things that I've done, prior to being made the administrator, I was the acting administrator since August 1st. And one of the first things that I did was when I called all the staff together for a senior staff meeting, I encouraged everyone to reach across, just because we have different offices here, reach across and talk to other bureaus within HRSA. Talk to other bureaus and agencies within the Department of Health and Human Services. We all work for the same secretary. So I wanted to make sure that people were reaching across lines, talking to one another, and making sure that they understood what the programs that they were doing and how those programs might be able to help their programs. We all work together. I want people to communicate and reach across lines.
Anyone on the phone have a question for Tom? I'll be quiet.
Thanks.
Please press star 1 if you would like to ask a question over the phone. Please be sure to record your name.
Well, I guess in closing, I was just advised that that the chair had a severe or had a heart attack.
Well, he's being evaluated.
Being evaluated for it. So I just want to extend my hope and best wishes to him and to all of you as he deals with that situation.
Thank you. And we did, Dr. Lisa Waddell from the March of Dimes had a question.
Good morning, Lisa Waddell with the Marching Dimes. We know that there are many places all across this country where there are no OB providers, no other providers, and so areas that we sort of define as maternity deserts. Can you speak to FERSA's role, involvement, guidance, direction around how to improve access in those particular areas?
Thanks for that question. That's a great question. We have, in fact, there was a series of roundtables that had been done on maternal health, and that came up. And we've also had a chance to talk with stakeholders about this. So one of the things that we're trying to do is get either in our health centers that we make sure that the primary care physicians, if there's ways that they can offer any OB services and help get that, because you're absolutely right. We've heard from some of the smaller hospitals, they say when they get taken over or something like that, the first thing, if they had any OB services, the first thing that gets taken out of there are those services because, well, they're not money makers for them, so they cut them out. But you're right, and that leaves a void. So we're trying to address the issue as best that we can, but we know it's a problem. And, you know, the interesting thing is I come from a rural area of Wisconsin. So I was joking with Tom Morris from our rural health office. I said, I grew up in Lafayette County, Wisconsin. To this day in Lafayette County, there is not a stoplight in the entire county. And if you ask the resident citizens there, it's the most agricultural dominated economy or county in the state of Wisconsin. And they'll all tell you, we don't want the farmers sitting with their tractors at a stoplight because they have to get to the fields. But my mom was the administrator of the local hospital, Lafayette County Memorial Hospital. And the doctor that delivered me, Dr. McGrain, was also my primary care physician growing up. And that's the way it used to be, but it's not like that anymore. And we need to find ways to make sure that people in rural areas have access to that care, because simply saying, well, there's a hospital 60 miles away, they'll be able to help you with that delivery, that doesn't help you when you're in the middle of a snowstorm in Wisconsin and trying to get there. So we want to make sure that there's, services that are there, not only for the delivery, but all during the pregnancy, because it's important for that mother, it's important for that unborn child, and then for the birth of that child to make sure that they have a healthy start in life going forward. Thanks for that question.
Steve Calvin, I work with midwives, and I was also a National Health Service Corps scholarship recipient a long time ago. Is there a midwife scholarship program? I maybe have to do a little more research about it, but one of our biggest problems is that we don't really have enough midwives. The workforce issue for OBGYN and family medicine is also an issue, but I would just ask that you keep it on your radar. We just need more midwives need to be trained, whether through the certified nurse midwife or certified midwife route. And there's also certified professional midwives, which is a separate category.
Okay. Thank you.
Good morning. This is Magda Peck. Can you hear me?
Yes, we can, Magda.
Excellent. Good morning. Thank you, Tom, if I may call you that. My name is Magda Peck, and I spent 5 fabulous years in Milwaukee as the founding dean of the Zilber School of Public Health at the University of Wisconsin-Milwaukee. And I want to thank you for paying attention to what I think is one of the sentinel cities in America. One of the challenges of a city like Milwaukee is the extraordinary hypersegregation and the underlying issues of equity, and particularly racial equity. And I was curious, in your role now as HRSA administrator, how do you see and how would you advise us to be looking at the health equity issues, the racial disparities that are so endemic in Milwaukee and the underlying and upstream causes? I was listening for that in your presentation, and I know it's there. I was just wondering if you could highlight your thoughts about that.
Well, I guess it goes back to the first question, reach across lines. I don't know what else. Is this reach across lines? A patient is a patient. And let's make sure that they all are getting the best care possible.
Thank you very much.
Hello, this is Jean Connery.
Go ahead, Jean.
I just wanted to say thank you very much for formally recognizing the importance of obstetrics and gynecology for infant mortality. I think having, I'm past president of the American College of Obstetricians and Gynecologists and president-elect for the International Federation of OBGYN. And I think the partnership between OBGYN and pediatrics in terms of understanding infant mortality is critical. And I would look to the programs that you are already supporting, our Women's Preventive Services Initiative that addresses well women health care, and then the AIM project, because those are two of the most important programs that we've got across the nation to improve the health and well-being of women before they conceive and during labor and delivery. So strong recognition. And being a Californian, I'd say look at outcomes. California has very rural parts of the state, very, very rural parts. So we've got California with the lowest maternal mortality in the United States and lowest, among the lowest of infant mortality. So even though it's a large state, looking at what California has accomplished is a good way of understanding what we can do in the rest of the nation.
Thank you for your comments.
California is also looking at the issue of the bundles in rural hospitals, because the bundles can be quite onerous given the resources in a rural hospital, to see if there's some modification that might need to be made. We all know rural OB units are just closed. And it's a structural issue. It's not an accident they're closed. So.
Yeah.
Others?
Thank you very much.
Oh, thank you very much for your time. I really appreciate you being here.
Thanks for your work.
Well, that's very fortunate. We appreciate having the administrator here. That perspective. Perhaps we could go around now and do our introductions, if David will let me. I have permission. How about if we start on the, do you have the names of people on the phone? Yeah. Okay, maybe you should call them, because otherwise we'll have people talking over each other.
Sure. So we've heard from Magda. So why don't we start with you, Magda? Why don't you introduce you?
Well, good morning, everyone. My name is Magda Pack, and I have multiple hats that I bring to the table with gusto. Currently, I have an independent consulting firm, MP3 Health, which focuses on health and equity, particularly focused on women and children around the country. I also serve as adjunct professor of pediatrics and public health at the University of Nebraska Medical Center, where I co-founded the School of Public Health. Founding dean previously in Milwaukee, and also I'm the founder and former CEO and now senior advisor to CityMatch. Based in Richmond, California, regret not being able to be with you today in person, and highly committed to this work of SACIM. Thank you for the invitation.
So I should also mention that, so in the briefing book that the link was sent to you all, there's also more detailed bios for everyone. Dr. Connery, do you want to introduce yourself?
Sure. Hi, this is Jean Connery. I am retired from Kaiser Permanente, so I spent 30 years of my practice in obstetrics and gynecology in Northern California with the largest health maintenance organization in the United States. I'm past president of the American College of Obstetricians and Gynecologists, and currently I'm spending most of my time in Europe because I am president-elect for the International Federation of OBGYN. I chair ACOG's Women's Preventive Services Initiative. So really looking at how we improve the health and well-being of women around the globe is my passion. And if we improve the health of women, then we've improved the health of the next generation. So that's certainly my mantra. Thank you very much.
Thank you. Janelle Palacios? I know you're online. Are you also on the phone? You're on mute if you're talking.
She has disconnected from the call at this time.
Oh, okay. We'll come back. Is there anyone else on the phone? I don't know if Colleen Malloy was able to join. Anyone else in the speaker's room?
I have
Hi,
Cheryl, Jean, and Dorothy.
This is Cheryl. Can you hear me?
We can.
Great. Hi, everyone. This is Cheryl Broussard. I'm an epidemiologist at CDC and an ex officio member of the committee, and I am the Associate Director for Science for the Division of Birth Defects and Infant Disorders.
And I'm sorry, I didn't get the second person operator.
We have Dorothy and Jean.
Okay. Dr. Fink, did you want to introduce yourself?
Sure. Good morning, everyone. My name is Dorothy Fink. I lead the Office on Women's Health through the Office of the Assistant Secretary for Health, and my medical training is in pediatrics, internal medicine, and endocrinology, and so I've cared for both infants and moms across the maternal and infant health spectrum, and I'm thrilled to be joining you all today. Thank you.
My name is Tara Sanderlee. First, I want to thank you for this awesome opportunity to be part of this committee. It really is a pleasure and an honor to be here. So just to tell you a little bit about myself, I am currently the Senior Fellow and Director of Life Sciences at the Charlotte Lozier Institute in Arlington, Virginia. But I reside in Wisconsin, so go Packers. I have a PhD, I'm a scientist. I have a PhD in biochemistry, was followed up by fellowship training in molecular biology at Harvard Medical School. I have 20 years of experience in academics and clinical medicine. I have led both research and clinical diagnostics labs at the Medical College of Wisconsin and Children's Hospital of Wisconsin. I've worked for many years within hospital pediatric settings, so both within the Children's Hospital in Boston, or Boston Children's Hospital and Children's Hospital of Wisconsin. So I have extensive training and experience in pathology of pediatric disease. I'm now involved in science and healthcare policy and practices that increase survival with focus on prenatal and early postnatal periods. I've also worked really closely with the Milwaukee Medical Examiner Office to understand factors that are implicated in SIDS, sudden infant death syndrome. So I have a particular interest in prenatal diagnosis and perinatal interventions that increase survival and outcomes for infants diagnosed with birth defects. So I think I will offer a unique perspective on this committee related to some of the inherent genetic factors that are contributing to these babies and interventions that are available to increase their survival. So thank you.
Great background. Thank you.
My name is Steve Calvin. I'm a maternal fetal medicine physician living in Minneapolis. And back in 1984, I did do a National Health Service Corps stint for 3 years at the El Rio Santa Cruz Neighborhood Health Center in Tucson, Arizona, where I'd actually also grown up. So why would I be living in Minnesota? So here I am. I have had a long career in maternal fetal medicine, and so I've delivered babies under a pound and handed them off to my neonatal colleagues. But over the course of time, I became really convinced that the maternity care system was basically designed in a way that was not acknowledging that pregnancy is not a disease, certainly has the potential for complications. So I spent time as a assistant faculty member at the University of Minnesota, done some basic science research. But over the last 10 years, I have begun to work with midwives and kind of went out on a limb to start the Minnesota Birth Center. We have 9 midwives working with us. We attend about 450 births total per year, some at birth centers that are alongside units close to hospitals. And I've also become very focused on the Medicaid population, both from my early National Health Service Corps time, but also just recognizing in Minneapolis, the zip code where our Minneapolis Center, we have two, one in Minneapolis, one in St. Paul. The Minneapolis Center, the 55407 zip code, is one of the most diverse in the United States. There are about 800 women with Somali background who give birth in our neighborhood, and we are very focused on trying to expand that option of care. So midwife team approach with physicians. And so I really believe system change is necessary, and I've kind of put my money and my time where my mouth is. And I believe that there really is bipartisan possibility here for really good things. And my ultimate mantra is healthcare reform should start where we all did, with pregnancy and birth, because I think it's an ideal episode, and I'm really glad that maternity care has been added in. So I'm also really grateful to be part of this committee and look forward to learning a lot from all of you.
Thank you. As we go around the room now, since most of us are not new members, if we could be name, rank, serial number will be pretty brief, so we have time for the actual committee discussion. I'd like to start.
Okay. Good morning, everybody. I'm Vijaya Hogan. I'm currently adjunct professor of maternal and child health at UNC Chapel Hill and an independent consultant in public health.
Hi, I'm Michelle O, the analyst for SACIM. Sorry, I thought it goes this way. I don't want to leave it. Hi, I'm Julian DiStefano. I'm a project officer in the Division of Healthy Start and Perinatal Services and help pull together this contract, but Michelle is out.
I think there's some seats at the table. You're welcome to take.
Apologies. There's not a lot of information here. I am Wendy DeCourcy, the ex officio representative from the Administration for Children and Families of the Department of Health and Human Services.
We have a spot saved for you, unless you scalped your ticket. Becky, we'll hear more from you later.
My name is Becky Abbott. I'm Deputy Director of Federal Affairs with the March Times, and I look forward to presenting a little later and talking about the Premium Reauthorization Act.
Hi, good morning. I'm Carolyn Stanfield. I'm the Director of Programs at the Association of Maternal and Child Health Programs, AMCHIP, and I'm here as a member of the public.
Good morning. I'm Lisa Waddell. I'm the Deputy Medical and Health Officer at the March of Dimes at our national headquarters and serve as our Senior Vice President for Maternal Child Health.
Morning. This is Paul Wise. I'm Professor of Pediatrics Health Policy and International Studies at Stanford University. I'm also co-director of the March of Dimes Center on Premature Research at Stanford. The new role that I played since last meeting is over to the federal court overseeing the treatment of migrant kids in U.S. detention on the border, responsible for independent evaluation of the situation and helping to mediate improvements with Department of Homeland Security and the plaintiffs representing the kids.
Good morning. I'm Belinda Pettiford. I'm head of the Women's Health Branch with the North Carolina Division of Public Health.
Good morning. I'm Admiral Wanda Burfield. I direct the Division of Reproductive Health, Center for Chronic Disease Prevention and Health Promotion at SACIM. I'm also a clinical neonatologist, and one of my colleagues today, Charlene Collinger, will be presenting information on maternal and infant health.
Hi, I'm Danielle Ely. I am the manager of the linked first infant death file for the National Center for Health Statistics.
I'm Laura Kavanaugh, and I'm the deputy at the Maternal and Child Health Bureau.
Hi, I'm Sarah Foster from CDC's Division of Reproductive Health.
Hi, I'm Teresa Chappell with HRSA and CHP.
Good morning, Dawn Levinson with HRSA Maternal Child Health Bureau. I'm the Behavioral Health Lead.
Good morning, I'm Vanessa Lee, also with MCHB in the Division of Healthy Start and Perinatal Services.
Good morning, everyone. Kimberly Sherman, HRSA MCHB, Women's Health Specialist. Good morning, everyone. My name is Casey McLaughlin from the Maternal Child Health Bureau and the Division of Healthy Start and Perinatal Services.
Good morning. My name is Lee Wilson. Thank you for coming. I'm the Senior Policy Advisor working for the Maternal and Child Health Bureau.
Thanks. And I'm Paul Jarris. I'm the Chief Medical Advisor for MITRE Corporation, not-for-profit federal government. And I reached the pinnacle of my career as second string to Ed Ellinger today. So, oh, great, Janelle. Could you introduce yourself?
Sure. I'm Janelle Palacios. I am a nurse midwife. I currently work in Northern California for Kaiser Permanente, and I am a past president of the Native Research Network, which is the largest organization of American Indian Alaska Native researchers in healthcare.
Great, Janelle. Welcome.
And good morning, everyone. This is Tiffany. I am the Director of the Division of Healthy Start and Perinatal Services at HRSA MCHB, also OBGYN and preventive medicine physician. Thank you so much.
Thank you. Well, why don't we go on with our agenda now? And if we go back to the other slides. Okay, this section was the continued update and review on the chair's one-on-one interviews with the SACIM members, and also an overview of some of the previous SACIM recommendations. And again, I'd appreciate it if people, if you have a question or comment, please speak up as we go. We don't have to wait till the end here. Basically, so we mentioned before the increased awareness of maternal mortality, and also increased awareness really on social conditions and the impact on maternal and infant health, often, of course, called the social determinants of health. In addition to this, and it was brought up, I think, by Vijaya last meeting we had face-to-face, I think there was also increasing recognition of structural and systematic disadvantages to certain populations. That is also something that often determines the social determinants of health and must be addressed specifically. You know, and that is now becoming very important throughout healthcare. It has been in public health. I think our ability to measure the social determinants and then use it as an intervention point is perhaps behind our rhetoric at this point. So it continues to be a challenge. Very clearly, there are tremendous differences, racial and ethnic differences in this country, and we really need to address that. There's no way to really improve and achieve what we want to achieve in maternal or infant mortality unless we address the racial disparities and the underlying causes of that, the structural and systematic and historic causes. And more and more we're seeing ACOG came out with a policy a year or so ago, great stuff coming out from the AAP, AAFP, and others really looking at about the impact of racism on child and adolescent health. It's been interesting to follow some of the consumer protection deliberations on different products causing infant mortality, perhaps not as speedy as we would like, but again, it's bringing up the issue of, once again, of infant mortality, safe sleep, and things like that, which there was also recently an article about bumpers and how they continue to be sold and are not regulated as a consumer product despite the harm that they cause. And I think we're dealing with probably a social, historical attachment to it, but very important area. We'll hear a little bit later about the March Times report card on preterm birth. Okay, I'm misfiring on this.
While we're waiting, Paul, can you just clarify for me, these are the comments from the one-on-one conversation?
I think this is still part of what Ed put together as background of the context about in which we're operating, which is, the context of increasing awareness, increasing resolution of some of the issues surrounding this. So I'll skip over this because Becky's going to talk a little bit about March Times report card, which unfortunately is, again, not particularly good news. Now we're into what Ed's discussion with SACIM members. There was uniformly, committee members felt that this is an important committee, that the country needs guidance. There needs to be a body that brings together maternal and child health to advise the Secretary, the administration on this. And I think that was acknowledged by the continuation of this committee. The responsibility and role of SACIM as a credible voice, as a credible scientific voice in this area, is again acknowledged as very important. And yes, we do have a mandate to advise and the Secretary and beyond, because many groups outside of the federal government look at the deliberations of SACIM and the recommendations. An acknowledgement among the different expertise and interests that come to bear at the committee, and the value of that, and the need for us really to utilize that and be inclusive in our discussions, so that we reach a sort of a higher common ground than we would otherwise. A need to stay focused on the science and make sure that we're very clear about when we are interpreting science, or when we're going, if we go beyond the science, that we are doing so, because unfortunately science can't keep up with life, especially in complex systems. So, but we need to be intellectually honest about it, and transparent. In a real sense that SACIM does have we can make a difference here if we really are clear about trying to influence the policy and programs at the federal level and perhaps beyond. Part of that bringing increased awareness, increased recognition of issues, new ways of looking at the issues, but new places to focus on. But it's not a given that we will be influential and impactful. I don't think for any of us the measure of impact is a report that gets written. We really need to figure out how do we stimulate action or decision making. Touched on this really about how we separate ourselves into professions, into camps, into pediatrics versus maternal health, state versus federal, and really then bringing those perspectives in an inclusive way to the table, and really leveraging them is the direction we need to go in, which means we clearly need discourse as opposed to advocacy-based conversations when we're talking. Rural health is a very clear priority in the administration. I think that presents us an opportunity because it hasn't necessarily been a priority in the past. The President has put out a directive on focusing on rural health. The Secretary of HHS has put out a revisioning rural health report. CMS has put out a report on rural maternal care. So we're seeing, and I know certainly HRSA is doing a lot of work in this. We're seeing a lot of attention here, and frankly, I think it is important. If we're looking at rural hospital closures, we've lost hundreds of rural hospitals. We continue to lose hundreds of rural hospitals. And even more so than losing the rural hospitals, we are losing rural maternity units. There are real structural issues there. So, for example, if critical access hospitals... Yes? Magda? Okay, well, so critical access hospital or a Medicare program, so if a critical access hospital provides maternity services, it does not go into their cost basis. Therefore, they lose money. They are penalized for maternity. And yet that's been, so that is a structural policy issue, the type of thing we really need to look at. Now, politics are real. They exist. To me, that means understanding the different points of view and why reasonable people have different points of view, but it also understands the language, means understanding what language means to different people and what their values are, so we can speak in a way that we can hear each other. And that is, I think, probably an art form we all continually to work on. But that respectful interaction is going to be so critical for us to maintain here. And one of the ways, of course, to do that is to be clear about what the science says and where we're beyond science and talking about values and beliefs, which are also very important. A real acknowledgement among the members that we can't build momentum with one meeting a year. And we have the additional disadvantage of not knowing whether the committee would continue this year, but to the extent it's possible to get together more frequently so that we can create some momentum, it's going to be very important. An acknowledgement that although our task is to report to the Secretary, and we're clear about that, other federal agencies are paying attention, but so are many more people. So we can have a voice, impact beyond that. Assumption, please. Yeah, good, thank you.
This is Belinda Pettiford. One quick statement, and I know we keep going back to saying stay focused on the science, but I do want us to be cautious that there's a lot that we don't have the science for that we still feel like would work. And so I just want us to be careful with using that language so that when we get moving into more some promising strategies or some promising practices, that they're not just looked at as not being important. So I just want us to be careful about continually saying stick to the science.
Incredibly important, because this is another area of turf wars and tribalism. Your science isn't my science, and my science isn't your science, and you don't think my science is real, and I don't think yours is real. So we run into this all the time. And in these complex systems, there are multiple social sciences that are incredibly important. The biological science is incredibly important. And really, we have to bring these things together in a way that, frankly, doesn't happen. I don't know, Paul, if you wanted to talk about that work, or Lisa. But this has been a real struggle.
Well, and I also think, this again is Belinda Pettiford, I also think it's the issue around how we engage communities and the voices that we bring to the table from communities, that it may not always be science-driven, but they know many times what they need in their own community because they know how their community is set up, they know the structure, they know who can get what done, but it doesn't always follow our science.
Yeah. Agree completely, and I think one of the places we fall down is on implementation science. What works in one community doesn't work in another. So, and later when we look at the evolution of some of the recommendations, I think we will also see that the move toward maternal and child health together, that was the real accomplishment of this committee, frankly. And then the voices you just raised, equity enters later on in the conversations over the years, and then really more of a public health approach will enter. As we look back at the different recommendations that came out, you can see that evolution to a broader approach to all this. One of the things that a lot of the members felt like is things are actually, from the data we have, getting worse for moms, for babies, so we need action now. I think Pat Libby, those of you know, just talk about awfulizing, and it's really easy to awfulize or wring your hands louder, but one of the things we have to really think about is, okay, what is it that we can do? What kind of decisions, recommendations can make a difference? Because, and that is a challenge. It's and perhaps Dr. Barfield will be able to enlighten us a little bit more about why we're seeing what we're seeing in terms of things getting worse, because without knowing that, it's also hard to know what do we go after, what do we look at. And I'll skip over the others of this. So this is Ed put this together based on a traditional versus an adaptive approach. In the environment I live now with lots of software engineers, they call this an agile approach. You know, historically we spend many years to write a report, try to have it be perfect, and then try to execute it, and by the time we execute it, everything's changed. And the notion that you do much more, you learn much more by taking action and then correcting your course as you go, as opposed to laying out the perfect report. So, you know, the 2 to 3 year time frames are wonderful. It's a great idea. Everything will change. And then when he mentioned about the predetermined strategies, it's because we all come with our favorite strategy depending on who we are and what part of the elephant we're feeling, and that's not been serving us well. The idea of the perfect document, there is no such thing, and you know, no document survives engagement with the real world. So instead of spending all our time writing that perfect document, we really need to think about a more agile way of approaching things. So, you know, more short-term objectives with a variable time frame, with corrective actions, which does mean we have to be active and together as a committee. We can't just do that once a year. Setting principles that we act within, so when the environment changes, at least we can look at it together with the agreed upon principles as we discover options. And the notion that it's not just we write a report, hand it off to the secretary, and we're done. That every one of us has influence and responsibility to use that for the positive good within our spheres. Nobody gets on this committee if you didn't come from somewhere. So really using that to spread the word of the committee in the appropriate way is going to be important. And then basically, I would call the last bullet here the sort of rapid cycle process, or a plan, do, study, act type process, which can work at the policy level as well as at a process level. So yeah, complexity science is an interesting one. I only skimmed the surface of it, but these things aren't linear. In a complex system, you can take an action. You really don't know what the intended and unintended consequences will be, so we have to really clearly pay attention to that. And also, especially when we're looking at different communities, socioeconomic levels, racial and ethnic groups, geographic areas, the impact of one community may be very different than another, depending on how something is done. One of the classic examples that was the introduction of colonoscopy, which lowered colon cancer mortality. Except it did not. It increased disparities because it wasn't implemented in a way that African Americans had the advantage, so the colon cancer did not go down at all there. It was an implementation problem. Probably not intentional, but it had the effect. So all those things you have to be conscious of. Again, no endpoint. This is going to be a continuous process, and really taking advantage, as we've heard today from Steve and others, of multiple professions here, and both the degree-based professions and community-based professions. So with that, I think those are the, this is Ed's inspiration, I think. But with that, I'd ask now if the committee, are there things here you see that don't quite resonate? Are there things here you don't see that you feel are important in terms of the committee consensus, or anything you'd like to reinterpret? Vijaya?
I'm still forming the thought, so excuse if I'm not coming out perfectly, but I think I heard a couple of things this morning from the administrator about cross-sector, which seemed to be contained within HRSA, when we understand that social determinants affect the health outcomes that we care about, which means people outside of the department are involved in this. And so I think we need to make that clear that multi-sector means broader than just what's in Health and Human Services. The other thing has to do with, I'm not sure which one of the comments spurred this thought, but it seems like we tend to be really reactive, and we think in terms of developing programs to address problems. But it seems to me that SACIM could be a body to set a vision for the country and for the field around what it is we're trying to build, what needs to be in place in communities to create the health outcomes that we're trying to get to. Because if we're constantly reactive, we're just plugging holes here and there, and we're not being holistic. We're not looking at the bigger picture and how these things interact with each other. And so I think SACIM could provide that vision of what that ecosystem looks like that we're trying to get to. And that could be, you know, says fly towards the center. That could be the center that we're flying towards. Because right now it feels like we're all going in different directions. We're responding to different impulses. So if somebody in California is doing something that seems to be working, all roads lead to that, and all the funds go to support that. We're not looking at the bigger picture. We're just sort of following problems and trying to solve problems. And I think we need to be a body that sort of steps back and reminds everybody, you know, what we're trying to get to, what needs to be in place to produce the outcomes that we're trying to get. Which leads to the third point, which is that it's not just healthcare. I mean, once somebody gets into the healthcare system, they already have a health problem. And we're trying to prevent that. And so there are things that we need to learn to do. I mean, we recognize social determinants, and we keep saying awareness and recognition. We've got to put the action word in there, do something about it, and we have to figure out what that looks like to address those, because, you know, the healthcare system is supposed to be the fallback, not the main course. We're supposed to pick up the cases that the social conditions failed. But if the social conditions fails everybody, the health system is just going to be overwhelmed, and we're going to keep chasing problems and plugging holes. So we have to start at that upstream level and figure out what role HRSA and maternal and child health and public health in general can play in addressing those social conditions. So I just wanted to put that on the record.
Thank you, Jai. Anyone that would like to respond or add to? Magda, I hear you're trying to speak.
I have my hand up unintentionally, but I guess it's meant to be. Let me just say, Vijaya, thank you for being so eloquent and expressing many of the views I would have liked to have said.
Just clarify, I do think that Tom's emphasis initially as he came on as the administrator was a focus on collaboration within HRSA, because that's within his immediate sphere of influence. But we have had lots of collaborative work that's underway with Department of Transportation, Housing and Urban Development, and others, just for your awareness. It wasn't limited to, I think that was his initial focus, but I think we've had much more extensive collaboration as well. Just so you're aware.
Or is there anything SACIM can do to help with that?
I do think over time, this concept of a common direction articulated by thoughtful people that is shared across agencies, we're doing, I think, a better job of convening around, certainly around maternal health than we were previously at different levels. So at the department level, Dr. Fink is on the phone. She is convening across HHS at the staff level. We're convening groups as well. But I do think the articulation of how do we move forward around a life course perspective? How do we move forward around social determinants of health would be welcome. I think that we're doing a good job of documenting needs and differences, but then how do we come up with an action plan?
Thank you. Janelle, I understand you have your hand up.
Yes, thank you. Vijaya, thank you so much for also stating what you said, because these are issues that I'm also thinking about when I go to bed at night, and I have a moment to kind of think without all the things in day-to-day life. We can look at our community representative that came and spoke to us, Tanya, and just look at the women who are incarcerated. That's a social issue. We didn't ask her how many of those women were in there for nonviolent crimes, but I believe most women in prisons, right, are in for nonviolent crimes. So, and they're now pregnant, and now they have a doula. So, to help and improve maternal health, right, it's going to be a huge social issue that we're going to address, and that's going to make some of the work uncomfortable, because it's getting at the social determinants of health. It's getting at health equity, and I agree. What do we do with that? How can we make recommendations on improving health when we include social determinants of health in every step that we take? Because if we're including the life courses perspective, if we can look at all the work that's been done on the ACE, the adverse childhood experiences and back, it's the context, it's what's going on. It's the things that happen that create one's propensity to develop diabetes or a heart problem, hypertension. So I applaud that. I'm excited to do this work, and I can't wait for us to start talking and having those uncomfortable discussions.
I believe that I need to double check, but I believe the World Health Organization has sort of criteria for the conditions that are necessary to have health. And that might be something we want to look at. It's also one of those areas where you quickly bump into values in terms of if certain conditions are necessary in the environment for a woman to be healthy and have a healthy pregnancy, what is the responsibility of our society to provide those things versus the individual's responsibility to arrange it on their own? So that would be an interesting conversation. Anyone else on the phone or in the room comment about the background?
This is Jean Connery. I just want to say I appreciate you bringing in the World Health Organization, because I think it is important for us as a leader to tie this into the Sustainable Development Goals. There are goals to hit by 2030, so as much as we can link this to what those goals are would be critical.
Thank you, Jean. Anyone else? Okay, well, we're much more efficient than Ed, looking at the schedule. So, right. That's because the second string doesn't have the content of the first string. So, why don't we take a break a little bit early here, and then we'll come back. Laura, if you're going to present a little earlier. Okay, so how about if we take 10 minutes, and that means 20 minutes be in your seats. No, 10 minutes if you would. Thank you. That's my excuse for running long. So now I'm really happy that we have the opportunity to introduce Laura Kavanaugh. Laura is the Deputy Associate Administrator of the Maternal and Child Health Bureau. She's well known to everybody in maternal child health. She served as a Deputy Associate Administrator since 2015 and 30-year career in government and academia, really with a commitment to improving maternal and child health. Before assuming her current role as the MCHB Deputy Associate Administrator, she served as the Acting Associate Administrator of MCHB from October 2017 to October 2018. And previously, she had key leadership positions in the Bureau, led the MCH Division of MCH Workforce Development, the MCHB Division of Research, Training, and Education, the MCHB Autism Initiative, which was a cross-divisional program including research and training. So we're very happy to have Laura here and look forward to your presentation.
Thank you so much, Paul. I'm going to try to provide a little bit more context for a number of the programs that Tom raised, so you understand HRSA programs, and then more specifically context around maternal health investments within the Maternal and Child Health Bureau, as well as our public health investments and infant health investments as well. In addition, Ed asked me specifically if I could provide updates on our National Survey of Children's Health. An upcoming needs assessment is about to occur as part of our Title V block grant program, and I'll discuss that further, as well as an update on the Healthy People 2030 objective. So I'm going to try to cram in a lot of information this morning, but I think the contextual information likely will be the most useful. I am representing Dr. Michael Warren at the meeting today. He apologizes that he is not with you. He would love to be with you, but he is on annual leave, but wanted to make sure that I emphasize to you and that you heard directly how important this committee is to him, and he is absolutely committed to the work going forward. Also, personally, I just want to emphasize what several before me have also emphasized. I deeply appreciate both your time and expertise that you're devoting to this committee. I think this is incredibly important work, and I am so hopeful that this can be really groundbreaking work over time. I appreciate the approach that you're taking. We don't need another report that's on a shelf. We have plenty of those. So how we can be more action-oriented as a Secretary's Advisory Committee, I deeply appreciate that perspective. So with that background, let me give you a little bit. Tom mentioned this briefly, but just as a reminder, we sit within the Health Resources and Services Administration, so we house. Can everybody on the phone hear me? I generally am not soft-spoken, but I'm feeling. Yes, you can hear me. Thank you so much.
Yes, that's fine.
Thank you so much. We house the Bureau of Primary Health Care, so community health centers across the country. Tom referred to these, as well as the Bureau of Health Workforce. So as we discuss workforce issues, take that into consideration as well. There are a number of investments here, and a number of you trained through some of those programs also. The Federal Office of Rural Health Policy also is housed within the Health Resources and Services Administration, and we actually co-funded a recent project called RMOMS that Tom alluded to, but I'll provide a little bit more background about that as well. I also wanted to emphasize that within the mission of HRSA, health disparities is called out explicitly as well, so to keep that in mind also. Within the Maternal and Child Health Bureau, we are a relatively small bureau with a huge mission to improve the health and well-being of mothers and children across the country. I want to talk about some of our foundational investments within the Maternal and Child Health Bureau. For those of you who might not be as familiar with them, the largest investment within the Maternal and Child Health Bureau, and it accounts for about half of our budget, is the Title V Maternal and Child Health Services Block Grant Program. So this is foundational maternal and child health public health support that goes to every state and jurisdiction in the United States. It's based on a formula, so it's based on the percentage of children in poverty within the state. The reach is very broad. The data I'm presenting here are from 2017, although we just posted new 2018 data
over 56 million people reached in 2017. It's now 91% of all pregnant women are reached through the Title V programs in states and jurisdictions, 99% of infants, and 55% of children. Of particular interest in the maternal health space, the support for maternal mortality activities historically has been partially or sometimes fully supported by the state Title V block grant program. You'll hear much more from the Centers for Disease Control and Prevention about their initiatives around maternal mortality review committees as well, but it's been a wonderful partnership of some support on the ground through Title V program, as well as leadership and support from the Centers for Disease Control and Prevention. Another foundational program within the Maternal and Child Health Bureau is the Maternal, Infant, and Early Childhood Home Visiting Program, or MICV. This is about a third of our budget. These provide voluntary evidence-based home-based services. They're focused on at-risk pregnant women and parents of young children. So looking at both parents and children together in the home, a trusting relationship developed by home visitors with families in the home setting as well. Again, the reach is pretty broad. 150,000 participants in 2018 across 896 U.S. counties and about 930,000 home visits. We've used rapid cycle quality improvement efforts to look at a number of indicators beyond the evidence-based practices that are foundational to all home visiting. One of those is around depression screening, where we've used a COIN approach, which we call Collaborative Innovation and Improvement Network approach. It's a rapid cycle quality improvement effort, where we were able to achieve 78% of caregivers screened for depression within 3 months of enrollment. The third foundational program I want to talk about before I segue a little bit to our maternal health specific newer investments is our Healthy Start initiative. You likely are most familiar with this one. This has been most closely affiliated with the Secretary's Advisory Committee on Infant Mortality for a number of years because the focus is on infant mortality reduction as well as eliminating disparities in perinatal health. So we're focusing on currently 101 grantees. These were just funded in this new cycle, funded in April of this year. So it's 101 grantees in 34 states, the District of Columbia, and Puerto Rico. These are community-driven efforts, and I'll talk about it more recently. We also, just this year, added a supplement to these grants to focus on clinical care, providing clinical care providers at Healthy Start sites to assist in care coordination to improve maternal health outcomes. And I'll talk about that a little bit more. So let's talk a bit specifically about maternal health investments at the Maternal and Child Health Bureau. In 2019, we received an additional $38 million to address maternal health issues, and we supported a variety of different programs. You've heard AIM referenced already. That's the Alliance for Innovation on Maternal Health. These are evidence-based maternal safety bundles. We're now through the AIM program, and this is overseen by ACOG in 27 states as of August 2019, and we've enrolled about 1,300 hospitals that are currently participating in AIM. We also just funded 9 states through the State Maternal Health Innovation Awards for a total of $23 million per year. We've expanded AIM with the new dollars to all states over time, and we're supporting, as I mentioned earlier, clinical providers at Healthy Start sites to the tune of $12 million. With AIM, additional funding went to support the existing AIM to spread and scale to all states, but we also funded a new initiative to look at community-based bundles, because we know, based on CDC data, that deaths occur not just in the hospital and a week postpartum, but up to a year postpartum, and how can we engage in a variety of different settings to implement bundles over time. The Indian Health Service has taken some of the bundles to implement with the IHS. We want to make sure we're spreading and scaling that even further.
Additional investments, sorry, brain and my thumb are not coordinated yet, in maternal health include a new screening and treatment for maternal depression and related behavioral disorders. That was $4.5 million funded in 2018. And I think Jean mentioned also the Women's Preventive Services Initiative, but we also support Bright Futures, which is pediatric a blueprint for preventive care. So we have both from birth through age 21 in Bright Futures and Title V, I believe, and then Women's Preventive Services that talk about a woman's life course of preventive services available. We also support the National Survey of Children's Health. I'll talk about that a little bit more in a moment because Ed specifically asked for an update there. But that provides national and state level estimates on key child health indicators and is an important resource for your consideration. I want to talk briefly about challenge grants. So for us within the federal government, these are particularly innovative ways for us to reduce barriers to entry to support new ideas and a grant program within the federal government. The application process is a couple of pages. It's reviewed by content experts, and we're looking for tech-based solutions to long-standing problems that we have been seeing for a number of years. The two that focus most closely to maternal health for this group's consideration include the MCHB Remote Pregnancy Monitoring Challenge. And I was surprised I was able to be a judge on one of these panels, so I got to hear a lot of these presentations. They focus not only on things that you would expect, like remote pregnancy monitoring of things that you normally would cover in a prenatal care visit, but also how do you develop a support system using technology for a caring support system for a mother who might feel either is in a rural area or doesn't have transportation to prenatal care, to have a support system of women seeking prenatal care. So think about that as well. And then opioid use disorder challenge as well as looking at quality health care for pregnant women struggling with opioid use disorder. So just so you get a visual of these investments and how they link together, sort of foundational and larger programs include the MCH Services Block Grant Program, Healthy Start that I mentioned, and MCV, which is the home visiting program. We had a first generation of AIM, and we're now into at least the second generation of AIM. We're looking at community care initiatives with AIM as well. Tom mentioned our moms, but very briefly I want to provide a little context there. That is for 3 grants that are jointly supported by the Federal Office of Rural Health Policy as well as the Maternal and Child Health Bureau, looking at how can we support systems that address access to rural healthcare services over time. What would payment models look like and those sorts of things, not just access to care, but how can we build more sustainable models. Those were just funded, so we'll learn from that investment over time. RMOM, the Rural Maternal and Obstetrics, we have to have an acronym because we're the government. Rural Maternal and Obstetrics Management Strategies Program. And I can provide the NOFO for that to show you what the, if you're interested in more details. The State Maternal Innovation, 9 states are looking at innovation. How can we support that over time as well? Next, I want to provide, Dr. Warren presented a paradigm for improvement of maternal and child health, I believe at the last SACIM meeting, but I want to provide this has been a little bit more developed over time, and I wanted to share this with you because I think it is well aligned with the direction that you're going in as a Secretary's Advisory Committee. So about a year ago, Dr. Warren came to the Maternal and Child Health Bureau in October of 2018. He came from the state of Tennessee. So he's been previously was a Maternal and Child Health Director. He run a state program and also was Associate Commissioner at the state level. And he wanted to develop a paradigm for how we could basically accelerate improvements in maternal and child health and what would that look like? We're looking at a number of persistent challenges. We look at it from a very broad-based perspective because we're responsible for the whole maternal and child health population. But I want to highlight for this group in particular, we continue to see unsafe sleep positions, maternal mortality rates continue to increase. Infant mortality, we're still losing 2,000 infants before the first birthday. These persistent challenges that aren't going in the right direction. So the paradigm that Michael has presented, and I think has been very well received by the field, is accelerate, upstream, together. And I'll talk about each of those aspects of the paradigm. So by accelerate, we mean that we have to accelerate the pace of change in improving MCH population outcomes. While we've made significant changes over time, like in some areas, like infant mortality, we can't be complacent about the pace of change, and we haven't been able to eliminate disparities in many of the outcomes. So we want to accelerate our progress. I want to read to you, these are findings from a Bureau report to share with you these excerpts. Clearly, maternal mortality is a measure that is greatly preventable. No available figures show a decrease in the United States in recent years, and certain other countries now exhibit more favorable rates. What's so disheartening about this is that this came from a report from the Children's Bureau in 1916. We're seeing similar issues over a long period of time, and how can we accelerate improvement over time in a number of areas. The second aspect of this is upstream. So how can we start thinking about prevention? You've already discussed a number of these issues, but a greater focus around primary prevention. How can we think about two-generation approaches and a life course perspective so that we're impacting a person's health trajectory over a lifetime through intervening earlier and through preventive strategies. We're absolutely committed to the life course model. It's certainly something that we are trying to implement in a number of our programs to take not only the life course model across an individual's life, but intergenerational as well. In particular, the two-gen approaches that are most visible, I think, within our Bureau include the home visiting program, Healthy Start, and we also have a rural impact program that's looking at two-gen approaches. You all know this is not new information to you, but health accounts for only about 10 to 20% of overall health. We want to look at social determinants of health as well. And the last part of this paradigm is together. The science we need to share data, we need to share ideas, we need to investigate different issues from different perspectives. We need to use new methodologies that are going to require bringing new team members to the table as well. So how can we come up with strategies that allow us to do this together? This is just a little bit more information. We want to be supporting analysis and evidence-based strategies. Our block grant program is now, we're trying to drive change through that program. The block grant program has and we have added accountability measures that are trying to take the best available evidence and push improvements in maternal health outcomes. We want to make sure that we're reducing vulnerability and increasing resilience in high-risk populations, and that we're supporting innovation over time to make more rapid cycle improvements over time as well. I'm going to transition to much more detailed specifics that Ed asked me specifically to cover, but I wanted to pause for a moment and see if you had any questions about the programs first.
This is Belinda. One quick question, and I should know this answer, but I don't. With the McV program, what outcomes are they tracking? Are they tracking outcomes around infant mortality? Because I know when we started in North Carolina, we started with North Carolina Partnership before McV, right? Because we had some foundation funds and others. And initially, the conversation was more around child abuse and neglect, and so we housed it in our children and youth team, which made sense because they really weren't focused on maternal health, right, or even infant mortality. Right. But I'm wondering, has it moved more with McV to have a focus, or infant mortality and looking at the health of mom as well, or is the focus still more on child abuse and neglect?
So it depends on the model. Some models have more of a focus on child abuse and neglect. Others have, one of the benchmark areas is improvements around maternal and child health. So it depends on the model that is chosen by the state, but some of them do have a much heavier emphasis on the maternal health portion of it rather than not only the child health portion. And I understand there's a question from Magda as well.
Yes, thank you, Laura. Terrific overview. You had mentioned in your presentation on behalf of Michael and the Bureau, 9 states here, 34 states there, 101 communities. Has there ever been a mapping done of the United States and the territories, which allows you to see the distribution of the investment of the Maternal and Child Health Bureau dollars and its partnering dollars to see if there's gaps, like which states are not benefiting as much as others, recognizing that the base Title V is across the board. I was just trying to get a sense of when it hits the local level,
right,
and there is MCHB investments, and then there's Best Baby Zones investments, and then even if there are others, I'm just trying to figure out if you've mapped it out so that SACIM folks can see if geographically there are any significant gaps.
So on the HRSA data warehouse, we do have that capability. We can provide you with a map of all MCHB-funded programs by state. Yes, we can do that.
States, and I'm assuming, and can you map it also from a local perspective in terms of where are you directly investing into rural and urban communities, given we've been hearing this morning about certainly the needs of rural areas and cities like Milwaukee.
Right.
I just think it might be very helpful for, and also to the comment made previously about it's not just MCHB or HRSA, but across HHS, and even more broadly into, I believe someone was there from the Administration of Children and Youth. I just, if we're talking about trying to have more integrated approaches, I'm trying to figure out how we see where the money goes.
Yes.
And I just don't know if that analysis or a gap analysis has been done or differentiate between state versus local and tribal.
Yes. So several levels of response for you. We have better data at the state level. So for example, with the home visiting program, the dollars go to the state, but they have local implementing agencies within the state. We do have data that we can map on where the local implementing agencies are for home visiting. For Healthy Start sites, we have the data about where the grantee site is, but we currently don't have a map of the service area for all of Healthy Start. I'm looking at David for confirmation.
We had that previously, but with the new cycle of funding, where a lot of that has changed.
And Magda, absolutely to address your issue, we are actually working on a pilot project across HRSA to look at how can we map need and investments in a number of areas. But it's early on in the process. But we have the same interests that you do.
Thank you so much for that, because I think, and again, I tend to bring a local perspective through my CityMatch hat. I just recognize that there is opportunity in communities to braid and bundle, if you will, funding.
Yes.
Oftentimes the siloed approach, or having to go through the state tour then to the local level, can muddy the waters. And so the idea is greatest efficiency and greatest leverage of every dollar and greatest alignment. And I think that's one of the ways that following the money that SACIM might be able to be influential.
Thank you. I hear you, and we are on the same page. Any other questions before I give you more detail about the needs assessment and national survey?
As far as following Margaret's question, the other thing is if we look across or McBee or ACF programs or other programs. You know, some home visiting programs might be aimed at mom, some the child,
right?
And so multiple people can coming into a home. Is there or a look at that, or I mean, and for example, nurse-family partnership is they have to stick to their program.
Right.
That's a disadvantage. I mean, you know, and so it's broader than just nursing. It's across all of HHS.
Absolutely. So with the home visiting program in particular, there's a really close collaboration between HRSA and ACF because ACF oversees the tribal program, the national evaluation as well. So there is very good coordination there. What we are trying to navigate with the home visiting program is, I mean, the legislation requires that we stick with the evidence-based strategies that are approved and meet requirements for randomized control trials, et cetera. And we're supporting a learning agenda, so we're trying to do a better job of looking more specifically at what specific interventions work best for different populations, in addition to what we're learning through the home visiting model. That research network is doing some very interesting work. So we're trying to probe further about, so how do you develop, how do you address issues around opioid use, for example, that might not be part of the evidence-based strategy, but clearly are issues you have to address in the community, and how can you do some rapid cycle learning in that area as well? Does that answer your question? Yeah. Okay.
Laura, could I do a follow-up real quick?
Sure.
Thank you. I'm going to push you just charmingly a little bit further. As you know that I will do. What about, we were blessed this morning to hear the voice of a remarkable Ojibwa woman talking about her work as a doula in the incarceration system in Minnesota and in the prisons. That means that we're talking about the criminal justice system and the prison enterprise, which is totally outside of HHS, but still is a place where women are, who are, I love the language that was new to me about birthing people versus women. So I'm going to be thinking about that as it has helped me think in new ways. But when we think about incarcerated birthing people in her language, that implies that we need to work across sectors. So I'm wondering about the ability for HHS and, say, criminal justice, given incarceration and given opioids, about how that can work together also in being able to see model ways of tracking the investments and how they are leveraging each other, part one. And then part two, there's only two parts, is that I'm so impressed when I saw the announcement of Build Health Challenge recipients, I believe in 29 new communities, which is a multiple private sector investment, including the De Beaumont Foundation, Kellogg, and others, a large $600,000 grant for local impact in a particular neighborhood just hit Milwaukee, which will be transformational in the Sherman Park area. Similar, Milwaukee also has the Best Baby Zone funded by Kellogg through CityMatch, and obviously there are other local private sector philanthropy investments happening. So what is the ability for the Bureau, for HRSA, for HHS to be able to see the collective impact, or at least the synergy between the private investments that are being made, particularly at the zonal and local level, and the investments being made by the Bureau in Title V and beyond? So question A, question B.
I think I lost one of the questions, but there is a tremendous opportunity to look cross-sector. I think within the maternal health space, I don't know if Dr. Fink is still on the phone, but they are looking not only across HHS, but very broadly around maternal health and opportunities for collaboration there. I do think with public-private partnerships, we know of a number of those, and we're certainly open to talking about collaborative efforts there. I want to frame this as, what would you see the role of SACIM being in that process as well? We do have convenings of public-private partnerships where we share best practices and what our current investments are to learn from one another as a governmental agency, for example.
Very helpful. Thank you. I just want to put it on the,
Got it.
as we think about mapping. So thank you so much for your time.
Oh, thank you, Magda. I want to move toward a little bit more detail about the block grant. Ed had asked about this specifically. So the MCH block grant, I gave you a little bit of background. There are certain requirements of this block grant that 30% of the funds go to children with special health needs, 30% of the funds go to primary and preventive services for children, and no more than 10% can be spent on administration. So a great deal of flexibility in how states can spend the funds just within those broad parameters. And they are required to have certain accountability as well. So in the legislation for the block grant, every 5 years they conduct a needs assessment, and the opportunity to conduct that needs assessment is coming up in 2020. So there's an opportunity to look very broadly across a broad range of maternal and child health populations, and I think that the findings from those needs assessments, again, might be helpful to inform some of the activities of the committee. So a little bit about what comes out of this survey. There will be a summary that will come out of this that will talk about not only their process that they went through, but also their findings. It's due July 15th of 2020, and it'll be submitted by every state and jurisdiction, and then we will provide a summary about that's the process, which is, I mean, is important, but I think it's the findings that we might be might find most useful. These are around MCH population health needs. What is the capacity within the public health system, the Title V health system, to address those needs? And then what are the partnerships, collaborations, and opportunities for coordination? So that hits at a number of themes that we've been talking about here. In particular, I want to mention the family engagement and leadership as part of this process, listening to voices of families and women as part of that process. In addition, the home visiting program is conducting a needs assessment that is done we have tried to make very deliberately done complementary to the Title V program. That is due October 1st of 2020. The block grant has a long history of needs assessment. MCV, this will be the second needs assessment, providing insights into at-risk communities. All of the data from the states that we support through the Title V program and the needs assessments, once they're conducted, is publicly available on this website. It's the Title V information system. You can Google it. You don't have to remember the URL there. But it's a lot of detailed information about what's going on in states, how are they spending their money, what are the populations that are served, what are the evidence-based practices that they're implementing to address the performance and outcome measures that they've determined are the highest need for their state. One other activity I want to make sure you are aware of is our National Survey of Children's Health. This is now an annual survey conducted by the Maternal and Child Health Bureau. It's actually conducted by the U.S. Census Bureau, but the Maternal and Child Health Bureau funds it. It's a cross-sectional survey that goes to, the respondents are parents of children ages 0 to 17. It talks about a number of health issues, access to care, but also neighborhood factors and other more broad-based measures. In particular, in the 2018 data were just released on October the 17th for 30,530 children, and that's about 600. So we get national samples, but also state-based samples. And that's 600 from each state and the District of Columbia, and the data is available at that URL. Reem Gandor, who leads this effort for us within the Maternal and Child Health Bureau, wanted me to share with you that data collected are reported, are collected for about 9 months out of the year. So in a June-July cycle, January, February, we collect the data, and we release that data by October of the following year. And for those of you who work in surveys, she wanted me to share that you will know that this is practically lightning speed of availability of data. And it's publicly available within that 1 year. So just as a reminder, so the data are collected from parents and guardians in both English and Spanish. It takes folks about 39 minutes to complete the survey, and based on our testing of the survey. And I mentioned the results. Current activities, the 2019 survey is in the field. We're doing cognitive testing to inform content revisions for 2020. And we're also supporting our first year of state oversample, so for states that want to oversample for 2020. Validation is underway also for a number of new measures around healthy and ready to learn. Microphone instead of him. The 4 states that are interested in oversamples for your awareness are Oregon, Nebraska, Colorado, and Wisconsin. Something just keeps coming up today, doesn't it? Healthy people. I wanted to provide an update on healthy people for 2020. It's currently in out. It's provided to the National Center for Health Statistics, and end of the decade estimates will be uploaded in December to the website. We're always working on multiple versions, right? So Healthy People 2030 is now underway. 20 objectives have been identified for inclusion in the maternal, infant, and child health top area, with an additional 3 developmental objectives. I know that a number of you have contributed to the development and selection of objectives in the coming decade, and we so deeply appreciate your engagement in those activities as well. Core maternal, infant, and child health indicators, including things like birth outcomes and breastfeeding, continue, and new proposed content includes postpartum depression screening, illicit opioid use in pregnancy, and safe sleep environment. The launch for the 2030 data, or Healthy People 2030 objectives, is planned for March of 2020. So that's when you'll be able to see the objective descriptions, the baseline estimates, et cetera. I think I have covered the topical areas that Ed was interested in having me cover. I'm happy to answer any questions you might have about any of the areas.
Anyone at the table or on the phone have a question for Laura?
For those on the phone, if you would like to ask a question, please press *1 and record your name. One moment.
Laura, while waiting for that, I did have a question. I know Rear Admiral Gerard and I think Adams have been talking more about methamphetamine, particularly coming across the West, and I feel like in some ways we're fighting the last war and not the next war, not that opioids are going away.
Right.
How are we preparing for methamphetamine?
I feel like this is not my area of expertise, but what I'm hearing from a policy perspective is agencies are looking at all substances, not just, opioid got a lot of funding, and that continues to be an area of emphasis. But I think we're looking more broadly because methamphetamine is certainly, we're hearing that from our Title V programs and others as well, that's becoming a greater issue in some communities than opioids.
Hi, thank you. That was excellent. Just a quick question about the National Survey of Children's Health.
Yes.
So how many questionnaires did you send out total? It sounds like you got over 30,000 back, but how many did you send out? And how did you determine where they're, and who they were going to be sent out?
So it's a household sample. I don't know the response rate. I can get that data for you from Reem. I don't know that off the top of my head. I think it's about a 47. I don't know. I don't want to speak because I will miss. I can send you more details about that. It is sent to households across the country, and then the parent decides whether or not they'll participate or not. It's actually a web-based survey as well as paper survey, and we found over time that we were getting better response rates than what previously was done as a telephone survey.
Just a follow-up question, maybe is for the researchers. What kind of a bias do you introduce when you send out a survey to a home? For example, obviously you're going to have people that have a known address, I presume, but move quite a bit.
Right.
So who are we missing and who are we oversampling?
I would need to ask Reem to answer that question. I don't know the details for that. Sorry.
Just as a quick response, we're doing a series of fact sheets on the survey because in a lot of regards, the survey is being used as a model by the Census Bureau in some of the strategies that it's using to address some of those bias issues that you've identified, as well as interesting ways of actually upping the response rate. The things if you put a penny in, or you put $1 in, or if you have it, handwritten, or if it comes at a certain time of the year. So they're taking a great time to address some of the standard questions that are usually concerns raised with surveys. Are we reaching people who use cell phones and maybe don't have a regular phone? Are we reaching people who have a box? Are we possibly more transient? A lot of that information is available on the website, and we will provide it. There are also, as I said, a series of fact sheets that are coming out that are looking at specific topical areas of children's special health care needs, using the states and the measures that the states are using. So we provide that information to you, but it is a key area for us, making sure that the numbers that we're getting are representative of the broader population and disadvantaged groups in particular, which is our target population.
Okay, and I'll channel Lisa and Becky there. It's a dime you put in the envelope.
Got it.
Diane, you have a question or comment? On the phone, and you may be muted. Okay, and I missed Magda. If Diane wants to try and...
A quick question for Laura, if it's for clarity for us in SACIM and our scope. It's a boundary question again, Laura. I'm mindful of the measles outbreak in Samoa, and I've done work actually through the Bureau in a previous life in the territories. Does the scope of, I don't hear much mention about our territories, including Puerto Rico, and I was curious if there's, if that is something to be included as part of our scope at SACIM. Would be helpful to know, and when there are emerging issues like immunization challenge and a measles outbreak, which has direct implications for perinatal health, is that something that we should be aware of? Similarly, in a more chronic nature, and with extraordinary appreciation for the service of Paul Wise at the border, what is the boundary relative to the southern U.S. border, and given the extraordinary impact on women of childbearing age, women and infants, and maternal health, infant health, among this immigration crisis at the border, is that also something that you see within our boundaries?
So within the territories and jurisdictions, I don't think that there's any limitation there. In terms of looking at issues geographically, I don't see any issues there for SACIM as well. Remember, you are informing the secretary with recommendations, but I don't think that there are not limitations of topical areas that you can't examine.
Thank you.
I think that's one of those areas where sticking to the facts and not being judgmental is very important. There are children who have needs that have to be dealt with, and families. Other questions, comments? Laura, did you ever wrestle your phone to work? Diana, sorry. That's right, I'm sorry, Diana. Okay. Thank you very much. It was an excellent update and presentation. Appreciate you being here. Give our best to Michael and returning. So time check. We are about half an hour ahead of time, and we could take an early lunch break. Or if you'd like, we could have a March Times presentation and have a slightly late lunch break, about 15 minutes later. So does the committee have a preference? Becky, do you have a preference? No? Yeah, so why don't we take a break now and be back in 1 hour, which is 12:30, please. And thank you.
State of maternal and infant health in our country is not fine. But through the collective efforts led by individuals, organizations, and entities like the Secretary's Advisory Committee on Infant Mortality, it can be. Every year, I'll have a map up here in a second, but every year during November's Prematurity Awareness Month, Martyrdom grades the United States as a whole and each state in the country on their preterm birth rate. Our goal with our annual report card is to shed light on the ongoing maternal and infant health crisis in the United States. So how are we doing on that? As many of you, as all of you know, not great, not great. For the fourth year in a row, the U.S., more babies were born too soon in the United States, earning the nation a C grade. The preterm birth rate increased from 9.93% in 2017 to 10.02% in 2018. This troubling trend is nearly a decade of decline. So as you might expect, the worsening national picture does not signal good news in individual states. Between 2017 and 2018, preterm birth rates worsened in 30 states, while we have one state, Oregon, purple, earning an A-. We have 6 states and 1 territory earning an F. As this map shows, there are significant geographic disparities in preterm birth rates. Infants born in the southeastern United States are much more likely to be born early than those born in other parts of the country. So the disparities in preterm birth rates are not just geographic. Black, American Indian, and Alaska Native women are more likely to be born early than white babies. Alarmingly, Black women are almost 50% more likely to deliver preterm than all other women. This is unacceptable, and we must confront those issues that prevent all babies from having the best possible start. Our annual report card includes a disparities ratio, which measures progress towards eliminating those racial and ethnic geographic racial and ethnic disparities in preterm birth. This map shows each state's disparity ratio. Dark purple is worse than light purple. As you'll see, some states that received a good grade actually have a pretty bad disparity ratio. So I encourage you to review your individual state's report card to learn more about how it is doing in promoting healthy outcomes for babies, no matter their racial or ethnic background or where they live. So it is, I just shared a number of statistics about our nation's preterm birth rate, which is unacceptably high, trending in the wrong direction, and disparate in which babies are impacted. The same could be said for other key indicators of maternal health. Approximately every 12 hours, a woman dies due to complications resulting from pregnancy, making the U.S. one of the most dangerous places in the developed world to give birth. For every maternal death, another 70 women suffer life-threatening health challenges. That's 50,000 women each year. Black women are 3 to 4 times more likely to die from pregnancy compared to their white peers. American Indian and Alaska Native women are also more likely to die and experience life-threatening complications. So I think it's important that we know that we're not facing a preterm birth crisis. We're not facing a maternal mortality crisis. We're facing an infant mortality crisis. The health of moms and babies are intertwined. by improving the health of moms before, during, and after pregnancy, we can increase the chances of full-term healthy birth and also improve the health of mom beyond the pregnancy and delivery. So this crisis has a significant financial impact on the United States. Each year, preterm birth imparts a societal burden of $25.2 billion. But just as importantly, the numbers and data I shared represent the stories of real people. The twins born 10 weeks early who spent 6 weeks in the NICU before heading home. The new mom who develops preeclampsia after her delivery but can't get to the doctor in time to treat the life-threatening condition. Or the parents who return home to an empty nursery because their baby did not survive an early birth. And it is with this understanding of the urgency of the issue that March of Dimes embarked on our efforts to repass the Preemie Act in 2017. So an important question today is, what is the Preemie Act? It is the only federal law dedicated exclusively to preventing and treating preterm birth through activities at CDC, HRSA, and this committee, the Secretary's Advisory Committee on Infant Mortality. I'll start off with a little legislative history of the bill, and then we'll talk about exactly what activities it authorizes. Congress first introduced the Preemie Act in 2003. I will tell you that it is not a coincidence that that is the year that March of Dimes began its very concerted effort to address the nation's preterm birth rates with the launch of our prematurity campaign. As it was first introduced, the bill was a bit more robust than subsequent versions of the bill. It would have authorized research dedicated exclusively to preterm birth at the National Institutes of Health, and HRSA's activities were a bit more comprehensive. But as often happens, the bill was pared down through the legislative process, and the final provisions in that original bill closely mirror those that are still authorized today. We'll talk about those details momentarily. It took us 2 sessions of Congress to pass the original Preemie Act, but it was ultimately signed into law in December of 2006 during the waning days of the 109th Congress. Generally, public health bills are authorized for 5 years, and the Preemie Act is no exception, and so we will fast forward 4 years to 2010, and it is time to begin our efforts to renew the Preemie Act. The first reauthorization effort fell victim to the congressional calendar. We were able to pass the bill in the Senate and the House, but those bills weren't identical. So, and then the Senate didn't pass the House version, and so we had to start all over again in the 113th Congress. But the Preemie Act was introduced early in 2013 and signed into law by November. So 4 years later, March of Dimes begins our work on with our stakeholder partners in 2017 to lay the groundwork for introduction of the Preemie Reauthorization Act of 2018. The bill was introduced in June of 2018 by Senators Lamar Alexander and Michael Bennett. Senator Alexander's from Tennessee, Michael Bennett's from Colorado, and Congresswoman Anna Eshoo of California and Leonard Lance of New Jersey. I must say that we had a wonderful group of dedicated sponsors that care deeply about this issue and are committed to the bill's passage. This same group of sponsors was also our sponsors for the first reauthorization effort, and actually Senator Alexander and Congresswoman Eshoo sponsored the original Preemie Act. So true champions for moms and babies and infants infected by preterm. The latest reauthorization bill was signed into law by December 2018, and that's just 6 months, which is the equivalent of ludicrous speed in Congress. We were very excited to see it get through the process so quickly. And that brings us to today. We are 1 year after passage of the bill, and really just 2 to 3 years before we start the process all over again. Can I just close it? Javon was just here, and I don't want to interrupt you. So as I mentioned, the Preemie Act is the only federal law dedicated exclusively to preventing and treating preterm birth. Specifically, the bill authorizes activities at CDC to conduct surveillance and epidemiologic studies on preterm birth and its related factors. It also authorizes CDC to undertake efforts to prevent preterm birth An example of this work is its support of state-based perinatal quality care collaboratives, many of which have focused their efforts on preterm birth prevention, including reducing early elective deliveries. At HRSA, the PREMIE Act authorizes activities to educate the public and providers on preterm birth and its risk factors. The 2013 reauthorization also added high-risk pregnancies to an existing telehealth network that program that's operated outside of the Maternal and Child Health Bureau here at HRSA. So now we'll turn to the Secretary's Advisory Committee. While the committee has been in its existence since 1991, the original PREMIE Act for the first time formally established the committee in legislation and outlined its responsibilities. And with each passage of the PREMIE Act, your role and responsibility is refined a bit, tweaked, and modified given the times and what Congress cares about at that moment in time. For instance, the 2013 reauthorization required this committee to develop a plan for conducting and supporting research, education, and programs on preterm birth. Unfortunately, due to this committee's lapse in meetings from 2015 to 2018, the report was never released. Finally, I will flag that the PREMIE Act, under other, that the PREMIE Act provided support for the 2008 Surgeon General's preterm birth. The result of this two-day meeting was an agenda on activities in the public and private sectors to reduce the nation's preterm birth rate. We are 11 years later, and many of the calls to action in that agenda have been achieved, some have not, and there is still more work to do. So now we'll move on to the 2018 reauthorization and the changes it made. As reauthorizations happen, they are usually pretty surgical, pretty streamlined, pretty straightforward. So there were a lot of changes made in this recent bill. But I want to point out what the changes that were made and what they might mean for your work. At CDC, there was new language added to increase the focus on social determinants of health and CDC surveillance and study activities. It also increased the authorized funding for those activities by a big $120,000 to a full $2 million that CDC gets for preterm birth activities each year as long as Congress appropriates them. At HRSA, the PREMIE Reauthorization Act included new language that expanded the agency's public and provider education program to also focus, or explicitly focus, on maternal substance use, maternal mental health, and maternal immunization. For the Secretary's Advisory Committee on Infant Mortality, Congress updated your charge to explicitly look at health equity and maternal health, including maternal mortality and severe maternal morbidity. The reauthorization also now requires you to submit a report every 2 years to Congress on your activities and recommendations. Finally, the bill created a new interagency task force that would be led by the Department of Health and Human Services that would be focused on coordinating federal programs across agencies that impact preterm birth and maternal and infant health more generally. Members of that task force would all be agency or department employees, and their charge would be to identify duplicative activities and also gaps in programs and research. They would also be charged with developing unified metrics and goals for maternal and infant health activities across HHS. So that's what happened with PREMIE, and that's where we are today. So what's next? What does all this mean? March of Dimes and our coalition partners continue to collaborate with agency partners at CDC and HRSA in ensuring that the PREMIE Act provisions are implemented. And part of that is, from an advocate side, is including ensuring that we are protecting and increasing funding for CDC and HRSA so that they can actually do the work that we've instructed them to do. We are also in continued conversations with HHS on creating the interagency task force called for in the PREMIE Act that I outlined. So I will admit that those conversations are slow going, and I cannot guarantee that that task force will ever get off the ground. I think that HHS will be turning to this committee to pursue the goals that are outlined in that statutory language. And so there was a lot of talk earlier about collaboration and coordination, and I will just say that the Secretary's office says that you guys are in charge of that for the time being. We will also carefully monitor the work of this committee and other thought leaders to inform the next reauthorization of the PREMIE Act and other policy initiatives that we undertake. I will say that I mentioned that this committee was charged with creating that report on preterm birth and activities. And when we started to write or outline principles for the reauthorization, I reached out to HRSA and I was like, where's the report? I need that report so I can write good legislation and get you guys what you need. So I say that to you all just to know that we do, as advocates and organizations and stakeholders, look to this committee for thought leadership to guide the work that we do whenever we are meeting with Congress or the administration, and really are excited about the committee meeting again, renewed activities, and we do look for you for that guidance. So just wanted to put that plug in there. While I have the floor, I also wanted to update the committee on some additional federal legislative initiatives that might be of interest. As you all know, maternal health is very hot right now, which is great. Last year, Congress passed the Preventing Maternal Deaths Act, which codified and expanded CDC's work to support maternal mortality review committees. In this Congress, members in the House and Senate have introduced a number of bills focused on maternal health. They all have an acronym associated with MOM, so the MOMS Act, the Mommy's Act, the Mama's Act, the Maternal, so that's what they all are, but while all the bills are a little different, they certainly have themes and similarities. Many extend Medicaid coverage to 1 year postpartum. Others focus on reducing racial and ethnic disparities in maternal health outcomes with an emphasis on implicit bias and cultural competency training. Many bills seek to standardize and improve data collection, and the bill also authorizes some of those existing federal grant programs that you heard talked about earlier. AIM, hear about the Perinatal Quality Collaboratives, I'm sure. Some bills would create a maternity care home demonstration project to see how that works in improving maternity care for moms. And that one bill focuses exclusively on the needs of pregnant women living in rural areas that would create a rural health, maternal health coin and also some workforce training. So as I said, there are a number of bills, but at March of Dimes and across the maternal and child health community, people are pushing for what we are calling a momnibus. So really combining all those measures into one and seeing what we can get done in this Congress. So late last month, the House Energy and Commerce Committee approved and advanced 2 momnibus bills that combines many of the provisions I just outlined. The Maternal Health Quality Improvement Act does all the things I just mentioned except for the Medicaid postpartum extension, I should say. And then the Healthy Moms Act would allow states to extend Medicaid coverage to women for 1 year after the end of the pregnancy through a state plan amendment and give them a small 1 year financial incentive to do so. Oh, sorry. March of Dimes will on the Healthy Moms Act, March of Dimes would like to see legislation that extends, that requires states to extend that Medicaid coverage to moms, would require them to do that and would also provide a much more substantial financial incentive to do so. However, we are supportive of the Healthy Moms Act as an important first step in that process and are advocating for its passage. So we are hopeful that the full House will vote on these measures very soon and begin the process of working with the Senate to conference the bills to see if we might be able to get done before the end of this Congress in 2020. On the Senate side, the Senate Health Committee has introduced a bill called the Lower Healthcare Cost Act, which includes much of the language in the Maternal Health Quality Improvement Act, and will likely be the starting point for negotiations. I will say that those public health provisions are more likely to move than the Medicaid piece, although we will push very hard for that. They are cheaper. than the Medicaid piece. So that brings me mostly to the end of this presentation. I did also want to flag another couple of pieces of legislation that might be of interest to this committee, considering your charge. Healthy Start reauthorization has been introduced in both the House and Senate and is working towards passage. I think that one will move this year. It's a very bare bones reauthorization. Be on the lookout for that. And then also March of Dimes and a number of coalition partners are leading an effort to reauthorize the Newborn Screening Saves Life Act, and are hopeful that maybe we can get that done this Congress. There are definitely some roadblocks that we're trying to work through, but given the committee's charge, I'm happy to answer any questions as well. So with that, I am at the end of the bulk of my presentation. Before I close, I just want to offer a March of Dimes to this committee. During the opening session, I heard you all talking about how you would like to see this committee be the leader on maternal and child health policy in the United States, and we want that too. And we offer our service to you to amplify the messages that the recommendations, the reports that you put out. We would love to see this room more full, and we'll help you do whatever we can on that end as well, because we know that you all are the smartest folks we have on this issue, and we want to be able to amplify your message. So we're so excited about the committee starting to meet again, and look forward to working with you all going forward. With that, I'm done.
Thank you, Becky. Any questions in the room or on the phone for Becky of March of Dimes?
This is Jean Connery.
Hi, Jean.
Hi, I just want to commend March of Dimes always for their leadership for women and children. It's certainly, ACOG is always happy with our partnership and the collaboration, especially legislatively with passage of these bills. One of the things, my other hat that I wear is environmental and the impact of environmental exposures on health. And I would like us all to keep in mind the impact of air pollution on prematurity. We've certainly got areas in California where we closed down coal-fired plants. We saw the prematurity rates drop. So looking at environmental factors is certainly something that we need to be spokespersons for when it comes to our prematurity awareness around the United States. And along with that goes climate change and the impact of the climate, major changes in climate and how that has the potential to affect prematurity and maternal and child health. Thank you.
Thank you, Jean.
I will just say from a policy perspective, I know that there was a discussion earlier about, looking across federal agencies or federal departments. I think as we think about what the policy changes that might need to be implemented for that, the environmental health community is very siloed from the maternal and child health community. On the policy side, we don't interact a lot, and that's just because of bandwidth and goals and priorities. And so really appreciate you raising that, and to the extent that this committee can provide some leadership on what are those targeted recommendations to affect this, I think that those of us in the stakeholder and policy community would love to act on those.
Thank you. This is Jeannie again. And I'll point out that the American Academy of Pediatrics has a very active environmental section, and ACOG actually has a liaison so that the two, ACOG and American Academy of Pediatrics, are working collaboratively. We're part of the medical consortium on climate change. So it's certainly something that we are educating our healthcare providers about and advocating. But you're right, when it comes to bandwidth and all the different areas, trying to get everybody to acknowledge how important this role is difficult.
Thank you. Other questions on the phone or in the room?
For those on the phone, if you would like to ask a question, please press *1 on your phone and record your name.
Vijaya?
This is Vijaya Hogan. So with the PREMI Act, you said it was focused on prevention and treatment. Can you talk a little bit more about the treatment part? Specifically, I'm wondering if it just seems like there's a great life course opportunity in that act to sort of focus on the long-term outcomes of those babies as well, to make sure that their health is secure and their education is secure and the playing field is level, because eventually they're going to become parents, and you know their birth is going to impact the outcomes of their future birth. So is any of that built into the act?
Sure, and I would say that the kind of life course long-term impacts are not in this act. It is a pretty bare bones piece of legislation. The activities this authorizes are important but limited. I think where any kind of treatment issues come in is on the immediate care of the baby and that provider and public outreach that HRSA is tasked with. But no, there is not an emphasis, and definitely something we can look at for the next reauthorization, or thinking more creatively about how we can get that done through other avenues as well.
One other question about the maternity care home demo project. I kind of lost where that was. Which one of the acts was that a part of, and is that something that's being authorized, or is it already?
Right. So it is. It has not been authorized. It would be authorized if the. Let me make sure I have the name right. The Maternal Health Quality Improvement Act has that as a provision within it.
Any other questions, or anyone? Please. Go ahead.
Okay, so this is David. So obviously in my role as a DFO, and also as a HRSA employee, I'm concerned about the report that's due. Can you talk a little bit more about the expectation of how that gets done and how this committee, what is from the committee?
Oh, sure. Well, there is statutorily, I guess there is still the requirement that this committee releases that report. And that is what I can tell you about the expectation of that. The deadline has passed. It passed. Oh, what report? The preterm birth report or a different report?
Oh, the one that's in the 2018 2.0. The biannual report.
Well, that task force hasn't gotten created yet, so that's not really on you. So yeah, the task force. No, to my understanding, that was if that task force and when that task force gets created, that would be their responsibility. I guess my point was that that task force has not been created, and when we've asked why, they're like, this committee.
Are there other related interagency task forces that could pick that work up?
Yeah, that's a great question, and one that we will go back to in continuing conversations with the Secretary's office. I know that there is a new advisory or interagency committee on maternal mortality, and so maybe that could be woven into their work. We continue our conversations with them. I think why we pushed for the interagency task force is that we really, you all are the experts, but obviously are not federal government employees and aren't within the machinations of the department. So we're really hoping to have this other body to really work on that communication, collaboration, and really raising maternal and infant health up in those programs that maybe aren't traditionally talking about maternal and infant health, or maybe how they're looking at it is different. So we're really trying to coordinate across the department.
Was there someone on the phone? And then We'll go to Belinda.
This is Magda. A quick question. First of all, thank you so much for a very informative presentation, and as somebody who's working the March on Dimes at the local level, so grateful for the work. You started your presentation with data and with the upward curve towards 10% prematurity, and then you showed the maps, particularly around where there is both the grade, A, B, C, D, E, F, and disparity. I also will just note that Wisconsin sticks out, given that we're talking about Wisconsin a lot today, as actually getting a fairly high grade, but also being a high purple state. So I just want to say the March on Dimes data is something that's regularly accessible. My question, and that is, where do your data come from? And given that the strategic direction, number 5, from the previous SACIM was about investing in adequate data monitoring and surveillance to measure access, quality, and outcomes, and supporting other related data systems, where do your data come from? How do you see the March on Dimes data aligning with other data to be able to further a sense of urgency and a search of direction? What do you need, and what can we be doing to support your continued strategic use of data?
Well, thank you for that question. I will try to answer it, and then Dr. Waddell will tell me if I'm wrong here in the room. Our data mostly comes from CDC's National Center on Health Statistics. We rely heavily on that data, as do folks and stakeholders across the nation, to show the state of maternal and infant health and to make the case for action and change. It is a vital resource for us. I think that is where all of our data come, most of it, whether it's their surveys or vital statistics. And so at March on Dimes, and we work closely with our coalition partners to support the work of the National Center for Health Statistics, because it guides the work of the federal government, it guides our work and where we make our investments. And also surveys across CDC, PRAMs, the surveys we heard about this morning that the Maternal and Child Health Bureau does, all of them inform our work. And so I'm an advocate, so my hat is that we just all need to realize where that data comes from and make sure that they're well funded. The National Center for Health Statistics, its funding has been flat for a number of years, and those surveys that they're doing are threatened right now. How well they can sample, who they sample, and so it is imperative for folks to really raise the profile of the importance of the data and the threat that flat, stagnant funding has for those activities.
Dr. Waddell, how did she do?
She did fantastic, as she always does. But I would also add that data is incredibly important and incredibly valuable in helping to tell a story. And so the more that we have different types of data that you can layer and overlay and really sort of dig into, Magda, as you already pointed out, more specifically what's happening in a state or what's happening in certain geographical areas or communities. And so March on Dimes would love nothing more than to actually be sort of a repository of lots of sources of data to be able to really mine that and to get a more comprehensive picture of what's happening in order to try to ensure that interventions, programs, policies, systems changes are really being focused and targeted in the right places.
Thank you.
If I could add one more thing from channeling from the past, the state's a big area. I mean, what we really need for a state that is, for example, if they're doing well overall but poorly on the disparities, is to dive in geographically to their population groups to figure out where are the problems and what can they do about it. You can't get to it, obviously, from a level like this. And in every state, there is both good and bad going on. Belinda.
Yes, this is Belinda. So I read the Premier Act and was familiar with it, and then you mentioned quite a few other potentials that are coming down the pipe. is funding associated with any or some of them? And I'm not saying it because you always need funding, but for some things you think you would need funding. So the PREMI Act didn't include funding, correct?
Sure. So the PREMI Act, all authorization bills do is authorize funding, right? And then you have to get it through the annual appropriations process. I say that to say that the Division of Reproductive Health gets about $2 million each year through the annual appropriations process that is, I would say, earmarked within their budget for preterm birth activities. It is non-additive. It doesn't increase their funding. It's just, please spend at least $2 million. And I know that they spend more through their investments, but at least $2 million. HRSA, for their activities, we authorized the funding for those activities in the original PREMI Act, and it has never been appropriated. And so HRSA has continued those activities through the Infant Mortality Coin Project and other things that they've done over time, but there's never been a specific bucket of money associated with that. On the maternal health bills, I will say that it is an interesting thing in that Congress has already appropriated the money. So in the maybe 19 bill, fiscal year 19 bill, Congress, that might not be the right year, but I think it is, Congress approved a bunch of new money specifically dedicated to maternal mortality, and that went to HRSA, that went to CDC. And so they have used that to shore up their maternal mortality review committees, to finance the AIM program. And so that money that's being authorized, some of the programs that are being authorized in those maternal health bills already has been appropriated. Some of it is not, and so we'll have to go back and work with appropriators to try to find the money that's been authorized for those programs. Does that answer your question?
It did. I guess so. Like if you look at the maternity, the medical home model that is listed in one of the bills, I didn't notice that funding was associated with it. So I know funding is already out there, and HRSA and CDC has released funding. Notice of funding opportunity announcements. They've awarded grants for certain things. But as new bills are coming through, are you saying they'll have to go back and revisit those, or they may just not be funded? It may just be additional things that are approved, but it may not be a way to implement it without taking something else away.
Correct, unless we are able to get that money through the annual appropriations process.
Yeah, the funding for the PREMI Act activities is from existing funding that CDC has under Safe Motherhood. We still actually spend more money on work around prematurity and preterm birth prevention, but it's a subline that's pulled out from the Safe Motherhood authorization.
Sure.
Can I ask a quick question? I think, is it Lisa? You or Becky may know. So I was just looking at the March of Dimes blog. I don't know if some of you probably been aware of the McKenna, the 17-hydroxyprogesterone injection sort of blew up a little bit. Does March of Dimes have a relationship with the company? I mean, have they funded stuff for you folks to put you in a interesting position? For those maybe around the table, there was a purported intervention, preventative intervention using progesterone injections that was supposedly decreasing preterm birth rates, but it was the FDA that decided this doesn't have, the evidence isn't there. So anyway, it's kind of an embarrassment right now from a preterm birth prevention standpoint. And any comments about that?
So we like ACOG are certainly waiting to anything final comes out about that. We are going to, are not advising people to sort of change what their practices are or any of that kind of thing at this point in time until sort of final decisions are made.
Too bad, huh? I thought we had something. Any other questions, comments? Hey, Becky, thank you so much, and thank you for the work the March of Dimes does, and a very powerful advocacy group, and we're all very grateful for it. And now I get to introduce somebody who doesn't need an introduction, which is a job I can handle. Rear Admiral Wanda Barfield is Director of the Division of Reproductive Health with the National Center for Chronic Disease Prevention and Health Promotion at the Center for Disease Control. She's also serves as Assistant Surgeon General in the U.S. Public Health Service. She joined CDC in 2000 as part of the Epidemiological Intelligence Service and has worked in neonatal and perinatal health with a focus on racial disparities. In addition to a role at CDC, she's an Associate Professor of Pediatrics with the Uniformed Services University of Health Sciences and an Adjunct Assistant Professor at Emory University School of Medicine and one of the giants that walks the earth in maternal child health.
Thank you, Paul, for that introduction, but I really want to use this time to introduce another incredible person who's joining us here today, Dr. Charlene Krolinger. Dr. Krolinger currently leads the Maternal and Infant Health Branch within the Division of Reproductive Health at CDC, and she is doing leading a lot of the work that's related to the areas of interest for the committee that includes maternal mortality prevention, infant health, both morbidity and mortality, preterm work, and infant mortality work, as well as a newer team that's really looking at maternal health issues that include some focus areas such as maternal depression and mental health, substance use, diabetes, and cardiovascular disease. She also leads a group that does the surveillance of maternal health with respect to the assisted reproductive technology surveillance system. So prior to this, Charlene worked as the lead for the Maternal Child Health Epidemiology Program, which assigns senior epidemiologists in the field and provides direct technical assistance to states. So she has that experience, as well as being an MCH Epi assignee herself in the state of Delaware. So she also has that experience in terms of the field work, and it has also allowed a great collaboration with other federal agencies to, of course, include HRSA and CHB. So without further ado, I'd like Dr. Krolinger to give her talk about strategies for improving maternal health.
So apparently I couldn't handle the easy introduction.
Better? Thank you. Thank you for inviting me to be here today. I'd also like to thank my division director, Dr. Wanda Barfield, for recommending me to present on this topic. With the expansion of focus from infant health to the mother-infant dyad, I'm going to spend this time discussing activities at CDC, specifically within the Division of Reproductive Health, that intersect between both of these populations. And these activities are intended to improve maternal health and the health of the family. This is an overview of what my talk looks like. I'll start by giving some more background on the relationship. I don't think I need to repeat what folks have already presented today, so I might move through some of these slides rather quickly. I'll talk a little bit about pregnancy-related deaths, and then CDC's efforts to strengthen surveillance through assessment and quality improvement. We can no longer look at the health of infants and mothers separately. They are interconnected in many ways, and we know that addressing maternal outcomes improves infant outcomes. So I'm going to begin with maternal health and maternal mortality and what CDC is doing in this space, and then talk a little bit about how that affects the family. So I'll begin with how maternal morbidity and mortality relates to infant mortality. There are many medical causes of maternal morbidity and mortality. In particular, preeclampsia is also associated with infant mortality primarily because it leads to preterm birth. But these conditions affect women delivering at the right time and often in the right place. These maternal complications also impact infant mortality and are the third leading cause of infant death. More and more women have chronic conditions like cardiovascular disease, diabetes, and obesity, which can lead to complications during pregnancy and beyond. For example, hypertensive order and cardiovascular disease. 1 in 4 pregnancy-related deaths are related to these heart conditions. For gestational diabetes, 6 to 9% of women develop gestational diabetes, and having it increases the risk of high blood pressure and also delivering a large baby that may need to be delivered by C-section. Both mothers with gestational diabetes and their babies are at higher risk of developing type 2 diabetes later in life. Recent CDC studies showed that nearly half of all women are overweight or obese before they become pregnant, which is associated with a higher level of pregnancy complications. Gaining more weight than recommended during pregnancy can result in a baby born at an unhealthy weight and can make it harder for the mother to lose excess weight after delivery. This excess pregnancy weight gain may lead to future obesity for both mother and child. A CDC study showed that in 2013, nearly half of women gained too much weight during pregnancy. Additionally, smoking during and after pregnancy increases the risk of preterm birth, low birth weight, and sudden infant death syndrome, as well as problems with the placenta, which can be dangerous for the mother and the baby. Substance use during pregnancy, including alcohol, marijuana, opioids, can all lead to problems for the baby, including preterm birth, fetal alcohol spectrum disorder, and neonatal abstinence syndrome, or neonatal opioid withdrawal syndrome. Additionally, the environment a woman lives in influences health outcomes for both her and her baby, including health insurance coverage, access to a healthcare provider, conception health, housing, education, and other issues. It's important for facilities to have risk-appropriate capabilities and staffing so that women can access quality care and services so that they can deliver at the right place at the right time. So let's take a closer look at maternal mortality. Pregnancy-associated mortality is all deaths during a pregnancy and within 1 year following the end of the pregnancy. Pregnancy-related mortality is a subset of pregnancy-associated deaths. They're deaths from any cause related to or aggravated by the pregnancy or its management, including a complication of pregnancy. Aggravation of an unrelated condition by physiology of pregnancy or the chain of events initiated by the pregnancy. So I'll talk a little bit about the pregnancy-related mortality ratio, or the PRMR. So you'll see that on these slides, which indicates pregnancy-related deaths per 100,000 births. CDC has been addressing the issue of maternal morbidity and mortality for a long time. In the last few years, the issue has drawn considerable attention given all the devastating individual stories that have been highlighted in the media, and I'm sure we're all familiar with. Overall, each year, about 700 women die during or within 1 year of the end of pregnancy in the U.S. as a result of pregnancy or delivery complications. There are considerable racial disparities. My March of Dimes colleague mentioned them in her presentation. American Indian, Alaska Native, and Black women are 2 to 3 times more likely, respectively, to die of pregnancy-related causes than white women. And what makes the numbers overwhelmingly tragic is that data from maternal mortality review committees indicates that at least 2 of 3 of these deaths may be preventable. The overall maternal mortality rate in the U.S. has risen since 1999 and not improved over the past decade. The issues are complex for why maternal mortality in the U.S. is not improving, and unfortunately, we don't have the data that provide complete answers. Data from the Pregnancy Mortality Surveillance System, presented on this slide, are from an enhanced use of vital records data based on recommendations from a CDC and ACOG work group and implemented in 1986. To help overcome limitations of death certificates alone, PMSS incorporates information from birth and fetal certificates that match a death certificate. PMSS also incorporates review by clinical epidemiologists to determine which deaths are causally related to a pregnancy and a cause of death. There's a lot PMSS can tell us. For example, information on timing of death. About 1/3 of pregnancy-related deaths occur during pregnancy, about 1/3 during and up to 1 week after delivery, and about 1/3 between 1 week and 1 year of pregnancy. So the majority happen outside of the delivery hospitalization. And the causes of death, as you can see here, vary by timing. So why does better data matter? Because it gives us more information that can lead to better programs and interventions. For instance, the proportion of deaths due to hemorrhage and hypertension have decreased since 1987, while the proportion of deaths due to heart disease and other medical conditions has increased. Overall, heart disease and stroke cause most pregnancy-related deaths. PMSS data can also show us inequities increased by age, with the disparity for Black and American Indian Alaska Native women older than 30 years 4 to 5 times that of their white counterparts. For example, the disparity ratio for Black women compared with white women ranged from 1.5 among the less than 20-year-old age group to 4.3 for the 30 to 34-year-old age group. The pregnancy-related mortality ratio for Black women with at least a college degree was 5 times as high as white women with a similar education. Most telling, this disparity remains high, even among the most educated women. CMS data, through existing agreements with states, cannot provide state-level pregnancy-related mortality ratios. But when we group states into 3 groups, high, medium, and low, based on their overall ratio, and then within each group further calculate a ratio by race and ethnicity, we see that even in states with the lowest pregnancy-related mortality ratios, the ratios for Black women was about 3 times as high as for white women. The disparity is about 3 for each of these groupings. I want to emphasize that while pregnancy-related deaths are tragic sentinel events, these deaths represent only the tip of the iceberg of other pregnancy-related problems, including near misses and severe maternal morbidity. For example, while there are about 700 maternal deaths annually, there are an estimated 50,000 cases of severe morbidity. All elements of this pyramid need to be addressed to improve the health and well-being of our families and our nation. Severe maternal morbidity includes unexpected outcomes of labor and delivery that result in significant long and short-term consequences to a woman's health. Severe maternal morbidity is increasing because of maternal age, pre-pregnancy obesity, and pre-existing chronic medical conditions, all resulting in increased medical costs and hospital stays. This slide shows some of the severe maternal morbidity indicators CDC recommends for monitoring acuity, and those that have increased, decreased, or stayed the same over time. So what are we doing? Robust, comprehensive, standardized data systems are essential because they help us identify opportunities for preventing deaths among mothers and design effective interventions. Maternal Mortality Review Committees, or MMRCs, get the most detailed, complete data on maternal deaths, which they can then translate into effective programs that address factors contributing to those deaths. We currently have 41 existing reviews, including 2 cities. That leaves 11 states without reviews, including many that would be considered rural. However, we have contacts in every state, and we have momentum and more potential than ever before. All states are now in the planning stages of implementing MMRCs, which will give them better data to set priorities for action. One key tool that we've provided is the Maternal Mortality Review Information Application, which we refer to as MARIA, and I'll bring that up again throughout the course of this presentation. MARIA is a data system designed to empower the maternal mortality review community to create action through common language. CDC supports implementation of this standardized system by review committees through targeted technical assistance, trainings, and promoting successes. We now have 33 jurisdictions using MARIA committee decisions. In this way, the U.S. has more jurisdictions than ever before documenting standard comparable committee decisions of pregnancy relatedness, underlying cause of death, preventability, contributing factors, and recommendations for action and expected level of impact on every case they review. I want to emphasize my main point here, which is opportunities for interstate collaboration through common data. The common language used in MARIA also allows regions to work together and facilitates interstate collaboration for larger states with higher caseloads. CDC funds efforts of the 13 state perinatal quality collaboratives you heard about earlier, which are state-based initiatives that aim to improve the quality of care that mothers and their babies receive, as well as the national network of perinatal quality collaboratives to expand the reach of lessons learned on a national scale. PQCs play a critical role translating the information coming from MMRCs into quality standardized care for women and infants. CDC Locate, or the Levels of Care Assessment tool, additionally helps states and other jurisdictions monitor systems of risk-appropriate care in their regions, enabling them to show the capabilities and staffing services within levels of maternal and neonatal care among delivery facilities. I'm going to talk a little bit about each of these systems. There are challenges to tracking maternal morbidity and mortality based on vital records alone. To better understand the problem and solutions, again, we need better data. As a result, for some time, CDC has provided technical assistance to MMRCs. MMRCs aren't new, and again, they've been around for some time, but have historically been challenged to reach their full potential because they lacked standardized approaches and dedicated resources. In 2016, we began an initiative with the CDC Foundation to enhance CDC support to state MMRCs. These MMRCs review all deaths that occur within a year of pregnancy and bring together a number of different data sources to develop a more complete identification of death and an understanding of a woman's life and the events surrounding her death. MMRCs identify deaths by linking death certificate and birth certificate or fetal death records, an approach consistent with PMSS, which I mentioned earlier. However, MMRCs have access to additional information on maternal deaths, such as medical and social records, that allow a deeper examination of the processes and factors leading to a death than is possible from vital records alone. This combination of diverse data sources and multidisciplinary committees, including both clinical and non-clinical members, positions MMRCs to best provide comprehensive assessment of maternal deaths and identify opportunities for prevention. As I mentioned, this review of deaths is not new. The Fetal and Infant Mortality Review offers case review in the context of community action. Even today, MMRCs could learn strategies implemented by FEMA's community action teams. CDC is focused on adding the community context to MARIA. Child Death Review also uses a standardized national data system. CDC has created MARIA to standardize recommendations from MMRCs and is focused on developing reports to share information between jurisdictions. Our emphasis is on the systematic collection and use of data. CDC has built upon the lessons learned with the Maternal Mortality Review Data System initially launched with in-kind sources in 2011 for the development of MARIA. To provide you with a little more detail, MARIA promotes quality processes for data abstraction, case narrative development, and committee decision documentation. It's a platform for comparable data across states and ultimately enables multi-state reporting for national and regional action. CDC staff provide ongoing training for abstractors, analysts, and committees to use the system and is currently finishing a transition to a centrally hosted CDC system with support from additional congressional resources. Once the centrally hosted system is fully launched, only internet access will be required to use it at the state or jurisdictional level. Before Maria, each state level review was using different committee decision forms, and now Maria offers one. It's a standardized form so data for action are similarly captured across states and jurisdictions. Preliminary data used to create this chart were captured in a 14-state summary published this year and serves as an example of the leading causes of death data that we can get from MMRCs. Mental health conditions are captured and identified as a leading cause of death by MMRC data, but is missed when we look at vitals alone. Additionally, we can see that mental health conditions are a leading cause of pregnancy-related death, mostly among non-Hispanic white women. This is something we would have missed before, but now not only is it standardized, but MMRCs can make comparable recommendations among these differing jurisdictions. MMRCs not only look at the cause of death, but also the contributing factors at the patient, provider, systems, facility, and community levels. And of importance, note that on average, MMRCs identify 3 to 4 contributing factors for each death reviewed. This highlights the complex nature of maternal death and the need for a broad set of actions to focus on prevention. Additionally, CDC has recently made 24 awards supporting 25 states for the Enhancing Reviews and Surveillance to Eliminate Maternal Mortality, or ERASE maternal mortality program. This funding directly supports agencies and organizations that coordinate and manage MMRCs to identify, review, and characterize maternal deaths and identify prevention opportunities. This work will facilitate an understanding of the drivers of maternal mortality and the complications of pregnancy and associated disparities. Determine what interventions at patient, provider, facility, system, and community levels will have the most effect, and inform the implementation of initiatives in the right places for families and communities who need them most. This marks a real step forward towards advancing data and building upon our past work to be sure that states are making recommendations on prevention. Now, I'd also like to take a few minutes and talk about perinatal quality collaboratives. PQCs are working specifically to improve the quality of perinatal care. They're state or multi-state networks of multidisciplinary teams that improve measurable outcomes for maternal and infant health by advancing evidence-informed clinical practices and processes using quality improvement principles. PQCs address gaps by working with clinical teams, experts, and stakeholders, including patients and families, to spread best practices, reduce variation in care, and optimize resources to improve perinatal care and outcomes. Key strategies used by PQCs include the use of a collaborative learning model, where teams share lessons learned, common challenges and successes, and what works and what doesn't. Use of rapid response data to track progress toward meeting quality improvement objectives, and provision of QI science support and assistance to clinical teams. The ultimate goal of PQCs is to achieve improvements in population-level outcomes in maternal and infant health. Use of the perinatal quality improvement model has grown considerably since CDC support for PQCs began in 2011. With now almost every state in the country having a PQC currently working in a state or one in development, as you can see by the many states that are colored in the various shades of white to green. However, this map can be a bit misleading. For example, some states that have switched colors on the map and now have a PQC available are very new collaboratives or are just getting started. For example, Pennsylvania and California are the same color on this map, but they are at very different levels of development. While California has completed multiple initiatives and has demonstrated improvements in outcomes, Pennsylvania just launched their PQC in April 2019 and are just starting to focus efforts to improve care for pregnant and postpartum women and newborns affected by opioids. Although most states have an identified PQC organization, many state PQCs lack the resources to be fully functional and have yet to reach maximum potential to make measurable improvements in statewide maternal and infant health care and health outcomes. While we are really excited about the growth of this work, we also acknowledge that there is much more work to be done to increase PQC functioning in every state at every level where they can truly make a difference. Improvements in maternal health have been central to this work, which includes cooperative efforts in both the maternal and neonatal quality improvement initiatives that PQCs are implementing. This is a list of some of the obstetric and maternal initiatives that PQCs have been engaged in, along with some of the successful neonatal initiatives. Again, focusing on the mother-infant dyad. The California Maternal Quality Care Collaborative worked to implement a maternal safety bundle to reduce severe maternal morbidity from obstetric hemorrhage. This is a good example of a PQC in action. A major aim of this project in California was to demonstrate that implementation of maternal safety bundles can be scaled up to a very large number of hospitals, approximately 99 hospitals caring for 256,000 infants. Facilities that were diverse in size, ownership, and neonatal intensive care unit level, all on a limited budget. Severe maternal morbidity was reduced by 21% among hemorrhage patients, who were the target, and 12% among all women giving birth. In the Illinois PQC Hypertension Initiative, to improve the identification and management of new onset severe maternal hypertension, the Illinois PQC worked to improve the timely treatment of severe maternal hypertension. The areas in green represent the timely treatment in less than 60 minutes. The orange areas in greater than 60 minutes, and the red areas represent missed treatment opportunities. There was marked improvement in time to treatment during this initiative, which included other elements of the hypertension safety bundle as well, such as improving the frequency of patient education prior to discharge and increasing the percentage of women with severe hypertension attending follow-up appointments within 10 days of discharge. During the Illinois PQC Hypertension Initiative, the severe maternal morbidity rate among women experiencing hypertension at delivery was cut in half. Finally, I'd like to talk about maternal and neonatal risk-appropriate care. According to previous publications, less than half of states have a maternal or neonatal level of care policy, and among those that do, they are largely inconsistent with each other and AAP or ACOG SMFM guidance. The Levels of Care Assessment Tool, or LOCATE, was created to help provide standard information to support collaboration between jurisdictions. CDC partners with states to implement LOCATE, but the assessment is state-driven. LOCATE asks questions about hospital equipment and staffing, subspecialties and availability, self-designation of care, volume of procedures, drills and protocols, specifically for maternal emergencies, and transfers and facility level statistics. To date, these jurisdictions have implemented LOCATE in partnership with CDC. This is composed of more than 800 facilities in these 17 jurisdictions. So I'd like to present some data, and first I'll focus on levels of maternal care. As you can see, a large proportion of facilities LOCATE assessed as level 1 or level 2. But there are more facilities self-assessed level 3s and 4s than LOCATE assessed. To support women delivering in the right place, LOCATE provides questions on maternal transport. The majority of level 1s and 2s have a policy to transport patients to a high-level facility. However, little more than half of level 3s have a formal plan in place to receive maternal transport from a lower-level facility. Policy data collected when the ACOG levels of maternal care policy was enacted indicate that approximately 60% of states had state-level policies in place for maternal transport, and 1/3 had a policy for transport reimbursement. Only 2 states had telemedicine policy language specifying maternal risk-appropriate care. An upcoming publication from our HRSA MCHB colleagues provides a more recent up-to-date policy review on levels of maternal care. Overall, CDC's conclusions are that transport is vital for risk-appropriate care. It allows for timely provision of care and continuity of care. And while telemedicine has transitioned from an innovative way of practicing medicine to a practical and necessary tool in addressing the healthcare needs of our nation. The majority of states have the infrastructure for perinatal telemedicine implementation through established policies addressing the telemedicine areas of consultation, diagnosis, and treatment, but lack the specificity for maternal care. Now, I also wanted to show how LOCATE equally informs jurisdictions about neonatal levels of care. Although the AAP guidelines are somewhat more established, we see here that LOCATE assessment identifies more facilities as level 1 or 2, similarly to the assessment of levels of maternal care. And importantly, fewer level 1s and 2s are receiving high-risk neonates. In summary, at CDC, we are working to raise awareness and build support for effective efforts that can have an impact on reducing pregnancy-related deaths and other complications. CDC's work in understanding and preventing maternal and infant deaths falls into 2 buckets: making sure we have strong data and at the same time ensuring that women have access to quality care during pregnancy, delivery, and postpartum. The bottom line is stronger data can save mothers' lives. Our work with MMRCs is a critical piece of the national response to maternal mortality, but it's just one piece. MMRCs and the data they create are needed to inform and drive other maternal health initiatives to eventually address all aspects of the continuum of factors that lead to these tragic deaths impacting families and their lives. So, given the clear connection between maternal morbidity and mortality with infant health, this committee has an opportunity to address maternal health to prevent infant mortality. We can't disconnect or pull apart the mother-infant dyad. There are many things to consider, including the influence of the social determinants of health on maternal and infant health. Thank you. Thank you for your time and attention.
Fantastic presentation, so thanks so much, Harlan, for giving us all that information. Questions, comments from the group? Either on the phone? Good, please.
Yeah. So the Maria thing, is that you're working with ACOG on that, or is that levels of care? I mean, I assume you've been working with ACOG and SMFM on all of these things. Mm-hmm. Then having met with Maureen Phipps, who's now taken over on Monday, she just wanted me to pass along. I'm not speaking for ACOG, but I'm an ACOG member and an SMFM member. I mean, it's great work, and I think with your leadership, Wanda, it's moving along. So I think we're going to be able to get nationwide data eventually. Are you optimistic about that? How long will that take, do you think? Just to put you on the spot. Yeah.
I think we're working, first of all, we're working really hard to get that national data and try to build a capacity, particularly in states that may have either begun this venture or are starting to. And we also have a lot of support from CDC as an agency. Maternal mortality is now a winnable battle, and it's an area where we're reaching out to the entire agency for support in this. But I think it's still going to take time in terms of helping states and jurisdictions sort of change the way that they're also gathering data and getting data. And so the process of the review committee is, not a rapid one. But I think to the degree that we can move quickly, we're excited. And I think as we start to get more information, I think there'll be more momentum.
Paul, excuse me, Paul Wise. What's missing? It's a remarkable array of surveillance, data gathering, and analysis, and then feeding back into community settings. But what's missing? Part of our job is to identify gaps and to address them. For example, where is CMS? I mean, the financing of all of the activities. Where's HUD for housing, the creative uses of Medicaid? How do you see the needs being met, and how best can this committee begin to address it?
So I think you're absolutely right. One of the big gaps that we have identified and we're working on are addressing the issues of equity. And all of those partners that you mentioned could contribute to that conversation, whether it's for reimbursement of services or increasing access to quality care for women. I think that's a big gap that this committee could discuss.
Chanel? You might be on mute.
This is Magda. You got your, can I pitch one out?
Sure, please.
Thank you. Phenomenal presentation. Thank you so much. I am curious about how you're keeping up with emerging issues during the steady rollout of Maria and the eventual blanketing of the nation with the approach to maternal mortality review and the strategic use of data. Two examples, and I'm just wanting to know, how do you handle when the landscape changes and you're trying to be steady about moving forward with a set of tools and protocols that have been developed? Example one is the legalization of cannabis in a growing number of jurisdictions, and how your work around data, given that it was listed in one of the, I was thinking about the drivers of maternal health in your initial slides. What happens as things begin to change about what might be some new drivers or complicating factors, and as the landscape around drug use, legal or illicit, changes, and cannabis and its other associated products are flooding the marketplace in certain markets, how are you addressing that? So that's one example. And the second is mega data systems that are happening within large health systems, such as, say, Epic, and what it can be the alignment between the radical shifts in electronic medical record and standardized data systems, and how it links with the rollout of Maria and other data that you're using at a population health level. And either of those would be examples of rapidly changing context in which your data are trying to spread effectively. Thoughts about that?
Thank you for your question. That was a little complicated. So I will start, and then please, Dr. Barfield, if you'd like to add. I think we're very fortunate in that the states that we're working with who are very engaged in Maria are willing to roll up their sleeves, come together, and contribute to how we examine the data. We have many states that have volunteered to be a part of working groups. For example, we have thought leaders in states involved in addressing the issue of equity. We have states involved in considering how can the community be more engaged in implementing MMRC recommendations. We've even started to talk with states about the composition of their MMRCs. Who is sitting around the table with you? Is everyone represented? Who do you need? Who can help influence the recommendations that you put out? And our hope is that through these working groups with a smaller number of states, that they'll come up with guidance and examples that we can then disseminate more widely, not just to our 25 grantees, but also across the nation to the other MMRCs that we weren't able to fund in this initial round. When it comes to emerging issues, it's challenging. I will say one good example that I can provide is with the opioid crisis. One of the things that we did was sit around the table with MMRC leaders in states and talk about how we could address the opioid issue, particularly in those states that have been hardest hit. And one of the things that they talked with us about was enhancing review of overdose deaths, those deaths that occur outside the facility, because it's most often difficult to collect disparate pieces of data about why and how those women died. So we have a targeted number of states that are particularly focused on overdose deaths and understanding the contributing factors to those. There's more to come on that in the new year from us, but that's how we're tackling this issue. When it comes to broader big data systems, I think right now we're focused on developing and rolling out Maria to enhance surveillance. There's always room for improvement, and there's always room to add more. But I think what that more is requires some thought. EHR data, for instance, can hold a lot of noise. So we plan to work with states to understand what's important. What are the signals that we need to really be looking at that give us more than what we can see with the data we normally collect through our review committees.
Very thoughtful response. Thank you.
Yes, that was a wonderful response, and thank you for that great question. This is Wanda Bartlett. I just wanted to add that I think what has been really remarkable has been the team that's put so much effort in this work, in that they've really spent a lot of time with states. So in addition to reaching out to every jurisdiction to really try to identify what are some of the emerging issues, we have the fortune of having assignees in the field who have also brought some of those emerging issues out. One example I would just say with respect to the opioid crisis, Washington State started noticing NAS back in 2005 and actually asked CDC to do an EpiAid to try to better understand those issues. So I think it really is vitally important that we're listening to what we're hearing from communities in order to understand these often shifting areas and emerging issues. And with regard to thinking about, some of the social factors that we don't quite understand. So I think what was presented in Charlene's talk was not only, a better understanding of sort of those clinical drivers, but maybe even more importantly, a better understanding of the social drivers, because we know that a third of deaths are happening in the later postpartum period. And so what are those factors that we haven't even begun maybe to measure because we haven't quite captured them? And by changing also or expanding the characteristics of the Maternal Mortality Review Committee, we're going to get those experts so that we better understand some of the social factors that may be contributing to maternal deaths.
Sharon, can I ask a question about the locate tool? In speaking with some of the, first of all, the idea of having a objective way of setting maternity level care is a very good idea. I'll say that. But with many things, there are also unintended consequences. Some of the rural hospitals. So I was asking about the locate tool and supportive of the concept of objective levels of care, but also wondering about unintended consequences. And speaking of a number of rural hospitals providing maternity care, they often feel, justified or not, that these are standards established in academic high-resource centers that don't really apply in a rural environment, and that they are having care downgraded to a level where they need to transport things they believe they clearly can handle. One hospital in Indiana was discussing how because it's a rural hospital volunteer ambulance squad, they won't transport people long distance because it leaves their community with no ambulance. Therefore, they have to heliport women out. And typically the gap between what insurance pays and the bill is about $10,000 for these families who now have a $10,000 bill to be in. And so they're just talking about downstream many unintended consequences. And in other cases, particularly people with opioid disorders or mental health disorders, they simply won't go out for care. And so they're stuck in a sense. I'm wondering whether, is there some merit to that? I mean, what we've done is said we're going to optimize the care of individual women at the expense of the public health of pregnant people in that area.
So I think that they're all fair points. I would agree that there is benefit to standardizing care, but also the cost may be that in some places the care that you would have received would no longer be available. I think there are states that are thinking outside the box about how to address this. There are states that have implemented, for example, ECHO programs to provide telehealth to women in hard-to-reach areas or women that the distance or time to care is too great. So I think that states are thinking about how to address this. I think our job is to listen to them and understand what their innovations are and to bring that to light and disseminate it widely so that hopefully it becomes part of a standard.
One of the examples that one of the hospitals gave is that they actually were downgraded in their level because according to them, their standard required 24-hour, 7-day-a-week ultrasound technicians. And in a rural environment, they simply can't hire somebody to do that kind of call. And that's a case where I think you could, again, if that's true, and I can't independently validate it, I think you could make a case that you really don't need 24/7 ultrasound technicians because an OB is trained to do ultrasounds and you're not doing high-level complex ultrasounds in the middle of the night or on a weekend. Maybe it's arguable. But that's the kind of thing I'm wondering, are we really looking at that to saying, rather than the perfect, can we get to the best possible?
The way I would answer that is the locate assessment is not intended to be used in a way that judges or has an impact on hospital services. It's really a tool that states should use to begin those conversations about what a minimum standard should be. So if there is a state that is using it in that way, I think we would argue that really its purpose is for conversation, not for penalty.
That's a good point because they did say it was the state used locate, but the state set standards according to locate.
So I think there really may be an opportunity for us to think differently in terms of this issue of risk-appropriate care, and we also have to think about some of the underlying systems of rewards and penalties for the way that we're providing care to women and infants. And so how do we think about a system that rewards people for doing the best thing in terms of getting moms and babies where they need to be? And that might be virtually, through a telehealth system, or it may be transport, which we're not investing in. And so, I think particularly with this discussion around the rural conversation, we really need to reframe how we think that care should be given, because the bottom line is that there are circumstances where the resources are needed, and the question is, what are you willing to invest to ensure that that resource is there at the appropriate time. And unfortunately, many babies don't come on a schedule of 95.
I thought it was every full moon. But I guess the other question is, who invests? Other comments, questions? Rebecca?
Sure, I just had a quick question. Becky Abbott with March of Dimes. The issue of surveillance, we're so appreciative of the CDC and stakeholder partners for investing and prioritizing maternal mortality review committees and thinking through how we can get better and robust data on moms that are dying. I think that this committee has an expanded charge now looking at maternal morbidity as well. And I was hoping that you guys might be able to speak to some of the data challenges around gathering data on those near-miss experiences, some of the limitations in EHRs, and how you guys are looking at maybe improving or expanding surveillance on those issues, and what maybe this committee could do as recommendations if there are challenges that need to be addressed.
Hi, this is Wanda Barfield again. So I think the challenge of severe maternal morbidity is having, I think, some similar challenges to what the infant and neonatal experience had been in the past in terms of trying to think about a severity of illness index that that captures the severity of illness, but has these potential challenges based on measuring the receipt of care, because it's possible that you're not actually receiving the intervention, so how could you possibly use that to measure the severity? And I think that's, I think that's the challenge. How can we think about measures that would hold true regardless of the intervention so that we would truly understand the severe maternal morbidity issue?
Other questions, comments? One on the phone?
For those on the phone, please press *1 and record your name to ask a question.
Well, thank you for such an excellent presentation. And I have my copy, and I'm going to review it a lot more and probably call you about stealing slides from you. But really appreciate the fantastic work you're doing in creating an infrastructure across the country, really, to handle this going forward. So. You all.
We do have a question.
Oh, very good. Please go ahead.
The line is open for that.
Okay, this is Jean Conyer. I just wanted to commend CDC for all the work that they're doing, because I don't think any of the regions of the United States would have accomplished as much as has happened in the last couple of years without the work that's going on at the CDC, with both the data collection, the meetings that are being hosted on an annual basis to really inform people that that leadership has made all the difference in the world. So this is mostly a commendation and a thank you.
Thank you for your support.
And we also have a comment from, 1 minute.
Janelle Palacios.
Janelle, thank you. Your line is open.
Okay, thanks. This is a question. Given the, sorry, my computer is all over as I'm trying to do this, and I had to connect. With the data that was shared, we recognize that cardiovascular health is recognized as a culprit for the cause of maternal death and infant morbidity and mortality, such as hypertension, preeclampsia. Given the breadth of research done on diet, can you tell me if the CDC has been able to look into a plant-based diet, not a vegan diet, but a plant-based diet on improving cardiovascular health?
So this is Wanda Barfield. I can't say that we've been that specific, and I think we're really starting to better understand the broader contributions of cardiovascular disease to maternal morbidity and mortality. Within the National Center for Chronic Disease Prevention and Health Promotion is the Division of Heart Disease and Stroke Prevention, and we're really embarking on working with them far more closely. We actually have a new lead for the Million Hearts Initiative. His name is Larry, and I'm going to forget his last name. But he has a real heart for prevention in terms of the prevention of cardiovascular disease through the life course, and acknowledges and recognizes the need to understand how cardiovascular disease impacts women's health, maternal health, and infant health. And so that's a very exciting opportunity. They are now sort of lowering the age group as they're looking at Million Hearts, which I think is going to be particularly helpful, but I think also working with them to understand, where are other opportunities to identify cardiovascular disease risk far before pregnancy, and then think about those risks beyond pregnancy. And your point is well taken. However, your point is really well taken about nutrition. The issue of obesity and diabetes, you can't tease these factors out from cardiovascular disease. They're all interrelated. In our country, we're seeing so much metabolic syndrome for our children up into their reproductive age groups, which is also another major contributor. It's just that I can't answer what specific type of diet or change in our nutritional profile we need to do to address it.
Thank you. So we can take about a 15-minute break now. It's 2:15. Perhaps we'll be back at 2:30 and get started again then. Thanks for the great presentations.
Janelle, your line has been added to the post-conference.
Perfect. Thank you.
You're welcome.
The next section we have here, and we have between now and about, well, we'll get out a little early, but a little over an hour, as much time as it takes us. And we really wanted to begin talking about an overview of SACIM prior work that's been done, maybe some principles to discuss, and then start exploring going forward. And we'll have more time to do this. But I thought for this first section, it would be helpful if we have about 5 committee members on the phone, about 5 in the room. And so for those of you on the phone, if you want to speak, please raise your hand, because that seems to have been working. Oh, and there are people on the phone who are not on the media? Okay. So if you can raise your hand, a committee member on the phone who wants to speak, please do that. If you can't, just say, this is John, I want to speak. And I'd ask that let's initially keep this to committee members, and then I ask David every 15 minutes or so to remind me, and then we'll ask for comments from everybody else. But I thought it'd be nice to have a chance for committee members to talk. And also, we've had a lot of presentations today, questions and answers, but not a lot of true dialogue. So this is where I need to speak up, because it really this is where we do our thinking. We started. So to go through a couple of slides here, Ed put these up as sort of quote, simple rules or guidelines, guides to lead us in the direction we're going. And And I think it's first worth looking at these for an initial reaction. That doesn't mean we're signing them in blood or we have to follow them. But, you know, is there anything up here that isn't comfortable, or is there anything up here that, or that's not up here? And maybe I'll just read it for, let me ask the committee members on the phone, is there anyone who isn't watching online? How about a verbal no, 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 no?
Jean, Janelle,
Let's see, Jean, Janelle, and Aaron. Oh, that's right. I bet.
Magda are all.
And Magda, okay. I bet we're, okay. But, so I'll read it just in case there's a problem. We're on slide 14 up here now. And the, quote, simple rules that Ed put forward. Remember every baby and mother. You know, this is not about statistics. This is about real people. Center on equity, which is part of every conversation and everything we do. Listen to community voices, the engagement of community voices here and of people with their ideas, values, and real life experience. Build capacity and a continuous improvement, much as we've been seeing CDC talk about today, building a system across the country. Focus on those connecting points. How do we bring these systems together? And what we're looking at that is connecting points in failure analysis is often where failures happen at the handoff. Ask powerful questions and seize opportunities. So Belinda, you were going to say something, did you?
Yes, Belinda, the area I was looking at was listen to community voices. Is there anything in the charter that prohibits us for having a couple of consumers themselves appointed to the committee so that as we're listening to their voices, it's, you know, it's an equitable process, you know, as equitable as it will be, versus us just having consumers call in. I know Vijay and I talked to them about this, and we've been going back and forth on email with Ed about what's the best way to make sure we've got community voices and the voices of people with lived experience engaged in this conversation. So, I mean, is there a reason we cannot have them?
So this is David. So you can actually read straight from the charter. Members are representatives of both the public and private sectors. Members from the private sector may represent corporations and foundations, the religious community, consumers, health and other professional organizations, health plans, and employers. Members from the public sector may include elected officials and health and human services administrators from the state and local levels, including representatives of minority, rural, and urban interests. Non-federal members will serve as special government employees.
I think that is one of the powerful questions.
So if, not realizing, well, knowing that it may take a moment to get someone appointed, that's been kind, isn't it, David? Is there any reason that if someone is not appointed, but we really wanted their voice represented, that they can't be reimbursed for their time? Or do they have to be an appointed member to be reimbursed for their time? Because, you know, the rest of us sitting around the table are being paid by someone, or we're getting reimbursed for being here. So to bring a consumer to the table and not cover their time and expenses does not quite seem fair.
Right. No, so I agree. But you all will remember that you are special government employees and what had to happen to make you special government employees, all of that paperwork and all that stuff that you had, all the clearance and stuff. So the logistics company does have funds to reimburse a speaker. So we could always use that if you identify somebody to come and speak on behalf of, you know, or represent something or someone or themselves or whatever, we can pay those expenses.
Here, could you?
Just to clarify, we have 2 speakers that are allotted in the contract, so just keep that in mind when you're thinking of people. For meeting.
Well, but you'll remember that the next meeting will be virtual, so there'd be no costs associated with traveling somebody like that in, but we could be an honorarium if we needed to.
That also, I mean, there's also symbolism here. I think that's a nice short-term gap or stopgap measure. That's the best we can do, but it would be nice to have consumers as official if we have voting members. I think that's very important. maybe there's a way to help them through the 26 forms that we had to go through. One thing I might suggest then is if, I mean, there are groups who have consumers as part of them. Certainly, I mean, Head Start has a lot of contacts with consumers, Healthy Start. Also, March of Dimes has a lot of consumer representatives. So maybe if we want to, okay. So I'm wondering if we could send maybe Michelle some ideas about organization and that may have a consumer to reach out to. And I think that from discussions around where in healthcare and hospitals they tried to do this, it does mean that a committee member should spend some time ahead of time with a consumer member to say, let's go through the agenda, let's talk through this, so that, because you know, the lingo we use is pretty tough. We've been in this business a long time. But I think that's a great idea and question. Other comments from the phone or the table about some of these simple rules?
To ask a question on the phone, please press *1 and record your name.
This is Magda Peck. I just want to acknowledge that there's an alignment between Ed's simple rules and what was written in the recommendations from 2013 led by Kay Johnson. And I just encourage us as we move forward to be building on the work that has come before us. And I just want to acknowledge the source of his simple rules is not out of our head, but my understanding is that it was based upon gleaning from one of the attachments that we have looked at of the 2013 recommendations and from the conversations with each one of the SACIM members.
Thank you, Magda. Appreciate that bit of history. So we'll keep this and we can refer up to it, back to what we need. I'm going to go backwards because I thought it was an interesting going through the recommendations at a very high level from the different reports, and I'm also going to move. Downstream consequence of that statement. And this is one of there's a couple subcommittees in 2001, and this is early postpartum discharge. You may recall back in those years, 12-hour stay, and sometimes 24-hour stay, which we loved. We wanted to get out of the hospital. That's all right. Other people did not love. But it shows here how focused the committee was, at least in these two subcommittees, on health care in healthcare facilities. I think that shows how far we've come. Obviously, this is incredibly important. We don't want to minimize it. We have to have it. But I think as we acknowledge, we need to go way beyond this healthcare-centric approach. So there. And prior to that, low birth weight, again, the outcome being worked on is very much a, birth weight, immediate outcome of pregnancy and delivery. Research strategy, the molecular, genetic, biological, incredibly important. Of course, we probably didn't have the omics back then to talk about, so there's so many more tools here to take a look at. Service delivery and quality finally is entering in here. It's broadened a little bit, but it's still very biomedical science oriented. 2013 things really, I think, really did change, and these are 6 strategic ideas or big ideas that came from there, and you can see, although even at the time there wasn't a mandate to maternal health, people understood the life cycle in 2013 and started to pull that in, as well as a continuum of care rather than just labor and delivery. Talking about multi-generation and health equity, I think the 2013 committee really strongly recognized and endorsed that we needed to work on health equity, which was very important development here. So again, getting much more broad than it had been. The data, we've come a long way there. And then the interagency, public-private, multidisciplinary, I think, is an acknowledgement of course, the need in community engagement and the social determinants of health and the multiple different agencies that impact birth outcomes. So I don't know if anyone else wants to comment on what you're reading into this transition or the sort of trajectory, or perhaps you don't even agree with the trajectory. But so now come to where we are today, and I think it's remarkable and a very positive development that now this is actually written into charter. The things that many of the things identified in 2013 that we had to work in. So the charter has now come much more up to date in terms of the thinking in the field. Of the different, going back to 2013 and trying to build upon prior work, looking at the big ideas, I would just stop for a second and say, what, again, is there something you see here that you feel shouldn't be here, or is there something you don't see here that should be here, allowing a little bit of a room for interpretation of these 6 items?
Steve Calvin here. I would say maybe I'll go over here. In ensuring the access, there is something there that's related to financing, but one of the things that we're not going to get anywhere unless things are eventually paid differently. And I experience it as a person who's working with a team of midwives trying to do a new model, but then finding barriers sort of within the bureaucracy of payer systems and whatnot. So somewhere in there, if we can, I would think it'd be a number 2 of ensuring access to a continuum. By ensuring access involves figuring out how to encourage a better model of care or a better care system by way of just the finance and others. I mean, and that's going to take a lot of work. But otherwise, I think all of those things are important, and especially to the access to data and trying to break down barriers and then using kind of the same tools for everybody, CMS, CDC, on the state level, as much as can be possible, because that's where we would then be able to look at data from virtually every state and every kind of demographic to just take a look. And I know that's a big dream, but hope it happens.
If we take a systems approach, I agree with it. The resources can go under 2, because money is one resource, but human resources in the rural areas and some of the inner city areas is also a critical limiting factor for us. So and if we look at the systems that are becoming health deserts or maternity care deserts, most of them are a result of our policies and the way we pay and the way we distribute resources. Go up to Canada, you go out to some of the most remote outposts, and they have a fully staffed health center with providers, because it's a system that assures that access, even way up on the Hudson Bay and places like that. We have no such mechanism or policies to assure access is available to people. Private sector approach, really. Hybrid. Other comments or questions?
So I would like to add a couple of big ideas to the list. So I think a couple of things that seem to be missing to me are like this overarching sense of narrative change or ideology change. And there are many levels and many ways to approach that. I think we were talking earlier about just navigating the interagency collaboration, and what does that mean? How does that look, and how does it filter from the federal level down to the state and local levels? So people who work in transportation, for example, don't really understand what they have to do with maternal health, and so there has to be some sort of education to help people to understand where those intersections are. That's one level. The other level has to do with what I think it was CDC who talked about training physicians and other people around equity issues and some other things. There are just a lot of different types of sort of narratives and ideologies that I think need to be addressed, and that could be under a big umbrella of ideology. I don't see a policy issue up there, or, you know, sort of a broad look at policy warning sign, you know, something that is going to, again, filter down to local levels, but it just seems like there needs to be something in that arena. And then when you went back to the 2001, there were a lot of things that focused on research, and this one doesn't have anything on research. And I think that's important because, you know, evidence-based is great, but you also have to invest in developing the evidence. And NIH funds the science, and I know CDC and HRSA do fund some demonstration projects, but there really isn't a concerted effort to really seed development of an evidence base. And so I think, particularly when we're thinking about implementation and what works for implementation around equity, I think that's an important area. And there are other research areas I think that we need to start to see now to really get at the inequities, and we can talk more about that later. I think I mentioned earlier about that ecosystem and just sort of having a common vision that we're building towards. I think that could be one of the big ideas that we add to that. And the last thing is just to clarify something, and I could be misreading it. I think it's under number 4. I can barely see it. But I think increase health equity by reducing social, or by targeting social determinants of health. So those things are not equivalent. One does not equal the other. And I think that's one approach. That's an important and necessary approach, but it's not the only thing, and it's not necessarily going to lead to health equity. In fact, in some cases, improving social determinants worsens the inequities. So we just have to be careful with that language and maybe restructure that one if we continue with that.
Really very good points. And let me ask, someone's capturing notes? Yeah. Okay, good. I mean, I got mine, but they're all legible already. Really great points, thank you. And so we'll have to think about how do we organize this to keep it a small number of high priorities. And some of that may be elevating some of these ideas to one of the numbers, another might be putting some substance behind some of these numbers. But absolutely, the relation of health equity and social determinants, specifically the issues of racism and structural, historic, and others.
Just a thought to add. This is Wanda Barker. Just a thought to add to the Jaya's. You know, NIH actually has an implementation science institute. So, where are the opportunities to perhaps learn there in terms of some of that, you know, scientific work?
Then for future meeting.
So Allison Cernich from.
Oh, okay. And actually, I've been ignoring David as he's telling me we're at our 15 minutes for more conversation. So.
And so does Magda, the two of them.
Okay, so Magda, why don't you go, and then we'll go to open into comments up for couple minutes.
Great. A technical point first, colleagues, and that is that I really appreciate the slide that gives the headlines of the 6 big ideas. And I appreciate the extraordinary amount of work that our predecessors did to delineate some very specific recommendations under each of them. And I know that not everyone had an opportunity to read, of our committee members, the 2 attachments that were sent by Ed in the last couple of days, or necessarily to make it all the way through the briefing book. That could be note to self. Make sure we look at that tonight. But for example, under Strategic Direction 5, which talks about inadequate data, it does, as a specific, Vijaya, give priority to research. And I just think the idea of pulling upon that and elevating it up might be very helpful. Stephen, from a finance perspective, under Ensure Access, there is detail in particular about Medicaid coverage and about, and again, it was the time of 2013, and the Women's Health Amendment to the Affordable Care Act was just coming into play, but it was to maximize the investments and the mechanisms of the Affordable Care Act. I'm not speaking politically, I'm talking about policy that still is the law of the land. And so I think that it might help us, Paul, to, as we do our what's missing, is to build at one level down. And we might not have had adequate time to review each of those. So that's one point I want to make of what might be missing, and make sure that we're building and contemporizing. 2 quickie ones more. The first is around Strategic Direction 5. I heard from this morning's presentations from the March of Dimes, from our colleagues at CDC, and others about the strategic importance of data. And I would just encourage us to give a particularly deep dive into number 5, which could be also about research and data, but particularly data systems, and try to glean out a little bit more specifics about what our partners in the public and private sector, March of Dimes, CDC, others, are looking or suggesting there might be opportunities for us. We heard that as well about the PREMIE Act. So I want to give a shout out for Strategic Direction 5 and make sure we don't lose the wonderful opportunities put forth and ideas from this morning's presentations. And then last, because I do things in 3s, I have been working more recently with colleagues who are in social innovation, who are looking at the role of technologies as a way of being able to directly impact the health of women and infants. And I think that in these new technologies, which have not appeared in 1 to 6, particularly the power of artificial intelligence and algorithms that define that, and some of the more recent coverage in the news about bias built in to healthcare systems, artificial intelligence, the apps that are already manifest in Maria, but other apps that are out there. I would encourage us to put a bucket, if you will, about emerging technologies, cross-cut with the issue of equity, and cross-cut with some of these other dimensions of access, that it might merit its own futures piece given how rapidly technology is changing. Thanks for letting me offer 3 points.
Thank you, Magda. Maybe we can go to the phone, and then we'll come back to Paul and then Belinda. Was there someone on the phone with a hand raised? Allison?
For those on the phone, if you would like to ask a question, please press *1 and record your name.
Okay, so Allison, okay, you don't have Allison. Well, if you come back on, Allison, let us know. Anyone outside the committee would like to say, outside, anyone else would like to say something new?
This is Wendy from ACS. I just wanted to hit a couple of points that everybody else said. One was this idea of columns that would go across the 6 items. I mean, just one came up as far as technology is concerned, but I could see research other and other things that might enrich. And the good point that we should be looking at what is the sub ideas that were written out by the 2013. So they may already have basically some sub columns that went across everything, but that might be one way to get a bigger story about research or about technology or about some other issues, or even maybe about equity. That could be its own column across what other points we want to bring up. The other thing that I wanted to talk a little bit about was you guys talked about cross-agency work and then also changing the narrative across agency work and then changing the narrative with doctors was the 2 points that were brought up. And our office has been trying to change our narrative on equity issues through a series of presentations and discussions and brainstorming. And we've been reaching out to a number of agencies to hear how they're changing their narratives or what work they've been doing on this. And it's interesting, these huge variations in when we're actually asking concretely in the understanding or depth of thought or serious work that has been done and the understanding of a concept of social determinants and those types of things. So it's actually having that conversation with the doctors is one thing, but even with an agency, I could see that being a pretty big conversation. And we found some people who can teach us and have been helping us, but then there's many, that don't seem to have any action going on in that zone. So.
Was there a synopsis of that put together?
All in the works, but it's all in-house, trying to change our research approach, basically.
Oh, Paul, Melinda, and then you?
Yeah.
Okay.
No, go ahead.
This is Paul Wise. We're supposed to be providing guidance to the Secretary of HHS. And this may be at a different level of concern. But we need to recognize that the most fundamental threat to the health, well-being of reproductive age women, pregnant women, and little kids is that we're living in an aging society. In other words, that the funding levels at the federal level for the programs we all care about, that we're talking about, that we see on these slides, is shrinking relative to other parts of the federal budget, certainly the federal health budget. And do we have a responsibility or a role to first, before we go into all of the details that we must go into, is to make the point that the continued relative shrinkage of funds towards reproductive age women, kids, and pregnant women has to be addressed at the Secretary's level. The protections have to be built because currently we're living through structural trends that will continue to diminish the portion of the federal, certainly federal health budget that is in fact allocated to the issues we care about. And do we want to take this opportunity or view our role as providing guidance and somewhat some evidence for this, I think, is the most fundamental threat to all the issues that we're going to raise.
Very important point, and one I thought of anyway.
Hi, this is Wanda Barfield. So I think, in terms of thinking about these recommendations, some of them are, they are big ideas, but then the next step is the how, right? So, just taking one in terms of number 5. So how do we adequately invest in adequate data monitoring and surveillance systems? It's a nice word, but how do we actually invest?
And where? Look at vital statistics or the core of the system.
Yeah.
Linda, you were?
And actually that was kind of in line with my thinking, was trying to take it down to the next level, because these are still very broad, big idea recommendations. And even as I look at data, I think we tend to look at perinatal data, vital statistics. But if we're talking social determinants of health, we have to look at broader data systems than just the ones we're used to looking at every day. and really trying to think through how do we get to that level. And because many communities, you'll see they have high infant mortality rates. The same community may have high poverty rates. It may also have education challenges. You know, you may be looking at the school-to-prison pipeline issue. It's so many different things, but if we need to look at all of the data and not just focus on the perinatal part of it.
Who's done a good job of that? I know there are there's a number of different groups that have. It would be interesting to come and give us insights. Graham Center, I think. Well, I know in general people have. I don't know about maternal health, where they can be dug down.
So I think the challenge that Belinda was sort of alluding to is that there are all of these complexities, and in the various places where the complexities are the greatest, the data capacity is the lowest. So there are some examples, but those areas have really high capacity and have sort of matured in their relationships. I think about, one example might be Massachusetts and the all-payer data system that they have, where they're putting all of the different payer systems within one data set and then able to sort of address a broad array of questions. They also have the pregnancy to early life longitudinal data system, where they're linking vital records, hospital discharge, PRAMS data, DSAS, their substance use data, all together. But they have that capacity versus, Alabama, which is really still trying to understand the accuracy of vital statistics data today.
Sort of thinking more along like the Graham Center approach, or what coding company would be on education, crime, census data, and bringing all those different data sources together to give us a picture of the community environment as opposed to the specific health care in the community. But what do you think on that? But Kerwin Institute does some of it too.
Yes, I think that there probably are some data systems out there, but I'm just thinking about, the breadth and depth of those systems, particularly in addressing maternal child health issues.
Like in our own state, we take the data and kind of overlay it one on top of the other, and can do it at the perinatal care regional level. We've not been able to take it down to the community level yet and trying to figure out some geocoding. So if you've got the data, then it may not be as difficult. The question is the data source, the national data that could be, because that's what we would be looking at, is national data to see if there's a way to compare it in different parts. I don't know.
Yeah, excuse me. Yes, this is Tara Sanderly. One of the things I just wanted to address is that in addition to what Magna had talked earlier about emerging technologies, I think this is something that we need to give some serious concern, or we need to give some serious discussion to, especially in the area of in utero surgical interventions for some of the whole area of perinatal revolution, because there's so many emerging technologies now where they can diagnose that these babies have a birth defect very early on, and they can actually intervene. So, for example, babies that have spina bifida, they can do these surgeries in utero, and they're developing more advanced technologies such as fetuscopy. But there's some major issues with this because there's currently no accredited fellowship program available. So there are only a handful of places within the United States that offer very high quality interventions. And so what do people do in these rural areas, similar to what we were talking about before? How are they going to get there if women want this care for their child? How are they're going to have to pick up, they're going to have to move for the, during the pregnancy to have their surgery, and then how are they going to have child care? So there's just a lot of logistical concerns. So not only accreditation and fellowship is an issue, but insurance coverage and what they deem to be medically necessary. And then if they deem that it's not medically necessary, but then there's this amazing technology that is available, then there are clinical studies that that are available, but then not all these women are going to be eligible. So how do we make them eligible? How do we maybe expand that eligibility to some of these women, especially in rural areas? So I think there's some big discussions regarding coverage and access to these advanced technologies in order to offer high-quality care and access to these women that need them. Because it's not, and we know that they significantly increase the survivability for these babies. There are some associated morbidities with for maternal morbidities, but these are just amazing technologies that I think we need to be dealing with.
I wonder if a section on sort of emerging technologies, which could include some of this in utero surgery, but also CRISPR. I'm not sure we're going to answer that, but at least raising the question of genetic modification. We've had the one.
But I think also as we think about these advanced technologies, we still need to understand that there are some fundamental technologies that aren't available to low-income women. You know, getting more than one ultrasound for many women is not an option. And so how in looking forward to these other promising technologies, how do we make sure that we fundamentally address some of the, you know, basic needs of some simpler, more readily available technologies that can be made available to families?
Please believe that these newer technologies will be rolled out equitably. Anyone on the phone?
Again, if there are any questions, please hit *1.
One other thing that I think about, the new area for us really is maternal health and the maternal infant diet in terms of SACIM, because that wasn't really part of our charge in the past. I'm wondering if that's worth talking about how we want to approach that. Lisa always tells me what to do. How we want to approach that or include it in our work going forward.
And we do have a question on the phone.
Great.
It's from Allison Cernick. Your line is open.
Hello, welcome back, Allison.
So I was trying to press buttons that I was supposed to press. So I'm the Deputy Director of the Eunice Kennedy Shriver National Institute of Child Health and Human Development, and I've really enjoyed listening today. I'm representing Diana Bianchi, who's the director here, and we've been working with the maternal health group at HHS, but we also have an enormous portfolio of research on infant health and also infant mortality. We also have the Safe to Sleep campaign that we've been working on both from a rural perspective as well as with tribal nations and Alaska Natives. So I do think that research, as mentioned earlier, is an incredibly important piece of this, which I think is missing. And given the amount of investment both on the infant and maternal mortality side and maternal morbidity side from NIH as well as for healthy pregnancies and some of the programs that we have available to track normal pregnancies and birth outcomes, medication use, infection, hemorrhage, et cetera, and their impacts on infants, I would say that, I mean, it's a little bit too much just to offer in a phone comment. But I do think that research does need to be a major part of these recommendations. And to agree with Wanda as well, we contribute funds to some of the surveillance systems that she mentioned and also have researchers that are interacting with those systems. The other thing that we don't know is what are the requirements in those systems that we need to be able to make available to other states so that they can get similar data. And how do we help get those requirements sussed out? Do we do that through a repository? Do we do that through a larger data system where we can make it more accessible so the researchers can look at it and draw conclusions? And then how do we make data? We make a lot of data available on our pregnancy and our infant health studies. But how do we get that word out to researchers in the community so that they can derive more prevention and or intervention recommendations. So I think, to the extent that when you're talking about CRISPR, when you're talking about point-of-care technologies that can be extended for rural health, minority health disparities, and research in those areas, these are all things that NIH does and does very strongly. So I think, we'd be happy to be more involved in future meetings, but I think that if you're going to pursue some of those cutting-edge technologies in terms of fetal surgery, in terms of genetic sequencing and editing, newborn testing, that's really our bread and butter.
Sounds like you're volunteering for a presentation at our next meeting.
I'm probably volunteering Diana, but I think that, if that's the direction you're thinking about going, then we need to, I think NIH should be a bigger part of the conversation.
Is there consensus on that among the group? Very good. Thank you. Thank you. And the other thing, perhaps, the million-person sort of mega study might be interesting to know about how you're doing with engaging people in studies beyond the typical medical study.
So we just launched a pregnancy portal on the All of Us initiative. So All of Us and PregSource, which is NICHD's crowdsourcing research initiative to understand normal pregnancy and even other adverse events associated with pregnancy. This is an ongoing study that we have. We've just done a collaborative opportunity with All of Us where pregnant women who have enrolled in All of Us are referred to our study. And then we're going to share the information back with All of Us so that we connect it with their health records, we connect it to the genetic information that they've donated, and to the other surveys and anthropomorphic data that they provide. And we are seeing a rate of about 3 women per day entering that study. So that's a new collaboration that just launched the day after Halloween.
This is Belinda, and follow-up to your question, your comment there. So when you get the data that's entered into your system, do you capture it by race and ethnicity? I mean, do you have any demographic information on the women that are entering the information? I mean, are we reaching just certain populations or all populations, or who?
Right. So right now we are, before we collaborated with All of Us, we were largely reaching who you think we would reach in an internet study. So generally, relatively well-off white women. We are trying, and that's the other reason that we're collaborating with All of Us, is they have community outreach to underrepresented and biomedical science groups. So we are trying to increase our enrollment. We'd be happy to talk to any community engagement organization that would like to talk to us about how to increase that enrollment. We're also looking at tracking medications that women are taking during pregnancy, because many medications are prescribed to women during pregnancy. We don't know the impact of them on either on the pregnant women themselves and their outcomes, as well as on their child. So we are trying to increase that recruitment, and we're working with All of Us and as well as some community partners to see if we can get that different and engage people differently through that crowdsourcing research program. It's a great question. We do get the ethnicity data. We get education data. We ask about other social determinants of health. So we try to make it as broad. And we also return results so women can see how their symptoms compare to other women who are like them in their phase of pregnancy. So we try to do immediate return of results. So you're reporting this level of depression. What do other women report? Should you see a provider? And then we also have links out to evidence-based organizations like March of Dimes, like ACOG, AAP, to give them some information that's from trusted sources rather than just whatever comes up on the Google machine. And then also try to get them to understand when they need to see a provider.
Allison, this is Wanda Barfield. I just want to acknowledge and thank you for the collaboration with PRAMS in terms of trying to understand maternal and infant health outcomes for women with disabilities. I think that's really going to be an important opportunity for us to think about, again, this connection between, maternal health and infant health. I also just wanted to ask you, what do you see, since earlier in our discussion, Vijaya Hogan raised the issue of trying to anticipate and sort of be proactive versus reactive in this committee's work, and I was wondering if you could offer some things that you see in the horizon, particularly around maternal health, that NICHD is trying to think about.
Honey, we have a bold ideas call right after this. I think at this point we're looking at how do we better, and it's a great question, Wanda. I wish we had a magic wand. I think from NIH's perspective, one is to leverage the things that we know that we can do for other conditions and get those out to women. I think we know that we have some major challenges with respect to women who don't have regular access to health care. And so how do we help provide things like point-of-care technologies or in-home technologies to help them monitor status and know when they really need to seek treatment, because that may be a financial burden to them. We are talking a lot about how do we repurpose treatments for other conditions. So how do we treat hemorrhage using trauma medications? Are we using those? We have a trial going on in that right now. We also are really looking at prevention. So pre-pregnancy interventions, how do we do lifestyle interventions for women of reproductive age to put them in a healthier status? And then the bigger nut to crack here is advanced maternal age. So if you look at the data, one of our bigger risk factors is the fact that women are getting pregnant later and maybe entering pregnancy with more comorbidities, or that the age itself is a real risk factor. How do we better anticipate what the mechanism is that underlies that? Is it really sort of an age of mother issue, or is it the comorbidities? And I think that needs to be better teased out, especially with respect to morbidity, which is harder because there are fewer, obviously, people who die. And we're also looking at more effective treatments of things that place women at risk. We have a lot of studies going on now looking at asthma management, looking at ways that we can intervene to prevent gestational diabetes or better treat gestational diabetes and preeclampsia. Both us and the National Heart, Lung, and Blood Institute, as well as the National Institute for Diabetes, Digestive Disease, and Kidney Disorders. I think NIH has really recognized that we've got to come up with something that addresses this going forward, and so we're trying to look out on the horizon to see what are the immune factors we need to consider and what are the other treatment factors we need to consider of the known risks. And so that's the sort of things that we're thinking about right now. The data issue is a huge one, and Wanda, I think you're spot on that we need to see what works and then try and figure out how to get, and I know you guys have done a ton of work with the maternal mortality review committees, and so, we need better data on why these women are dying and when they're dying, because they're dying up to a year post. I mean, postpartum stroke is a huge issue, and we have available treatments to minimize morbidity from stroke, but we may not be recognizing the risk, and we might be able to do some things to prevent stroke in the first place. So, I think all of us really just kind of need to put our thinking hats on in terms of the risks and when they occur, and then the subsequent impact of the child. I think you would probably agree, Wanda, one of our biggest limitations is we don't link moms and babies at all in data systems. And there are countries that do this very, very well. We do not do it well as a country, and we also don't define pregnancy very well in an EHR and have that follow women so we know what risks accrue with each pregnancy. So I think there are some real data issues that we have to solve.
How about on the implementation side? So, for example, and I hope it's still true, that aspirin was somewhat effective, low-dose aspirin for women with a high risk of preeclampsia in terms of lowering the rates, even preterm birth, but there's also eclampsia. And yet, and I'm a couple of years out of date since I've been at the March of Dimes, when I go around the country and talk to obstetricians, they weren't doing it. And part of that was arguing over, was it 80 milligrams or 115 milligrams? I don't care, just give them one or the other. But so there we had, and unless somebody corrects me, a good intervention. We searched at the March of Dimes for any center that had systematically implemented it, and I think we found one in Boston. But otherwise, look at all the interventions that could have helped, and I'm going to take a leap here and guess that low-dose aspirin might help with postpartum stroke too. So who is that part of what NIH does? That kind of implementation science. What does it actually take to get people to prescribe and receive an effect?
Yeah, so we have a number of institutes that are sponsoring research that is implementation and dissemination based. So we have active funding opportunities for that. We have not seen an independent investigator come in with a trial like that in the implementation science domain. However, we are working on and will hopefully be announcing a large-scale implementation project in a global network that will be looking at aspirin. And then we do implementation trials. Some of our stuff for pharmaceuticals right now is in phase 2. We have not moved to full-scale implementation, but we do have 2 large networks, actually 3 large networks that work in this area that do inform clinical practice guidelines and can do implementation-based research. One is the Maternal Fetal Medicine Units Network. The other is the Neonatal Research Network. And the other is the Obstetric and Pediatric Pharmaceutical Research Centers, and so those are our drug trial centers. And so we have protocols going on in all of those, some of them more implementation-based. Unfortunately, many of them are in more urban areas, not in rural areas. We've also kicked off a new partnership, which we're hoping will expand as we move forward with the child environmental child health outcomes, the ECHO program. They have a pediatric clinical trials network within them, and we've partnered with them on neonatal abstinence syndrome work. And so we are in a site in a tribal nation, and we are also in rural health sites where we're trying to do the follow-up, and then we will potentially be doing a treatment trial through that mechanism using the Helping to End Addiction long-term dollars that were provided by Congress to NIH to research opioid use and pain management in response to the opioid crisis. So all this to say, we have the capability to do that work, and we have done that work for some specific things. I am not aware right now, though we have a lot of grants, so I may have missed it, but I do not think we have at present a domestic trial, implementation trial of aspirin. I do know we'll be working on a very large initiative on aspirin coming up very soon.
Yeah, I think FIGO may have been doing an international study, but still in the
No.
No? That's what I get for listening to Joe Lee. Anyway, or misunderstanding him. Please.
So, I mean, you asked the question. I think our recommendations are broad enough. They don't actually say infants as much. I think they're broad enough that maternal health fits into them. I think and when you get down to the detail is when you'll see where maternal health will come up versus where the infant health will come up. Because they seem to be very broad. I'm assuming like under improve the health of women before, during, and beyond pregnancy, that pregnancy and tenderness will fall in that category, that it wouldn't be a separate one, but it would fall into that category. So I think the recommendations probably won't change by including maternal health because they also go up.
Cheryl, on the line, did you want to add something?
Hi, yes, this is Cheryl. Can you hear me?
Yes, we can.
Great. So I just wanted to chime in about what was mentioned about the need for mom-baby linkage. Just to say that our division at CDC is leading a cross-CDC work group on this very topic and trying to establish this as a thing that happens across CDC surveillance systems and different topic areas. As part of that, we've also been collaborating with other centers, including Wanda's division, of course, about trying to get pregnancy status added to all of the data collection systems across the agency, across various topic areas, to just make sure that that is something that is important and routinely collected. So I think that's gaining traction at the highest levels of CDC, and we're excited about that moving forward.
Great. Yeah, perhaps in that area also around yeah, there'll be a lot of probably recommendations on the data systems and the need to create those linkages. But also even within practice, it seems that some of the perinatal quality collaborators take on either a maternal project or a pediatric project. And I hope you'll tell me I'm outdated.
Yeah. Hi, this is Wanda Barfield. That's actually changing and evolving. So I think in the sort of growth and development of a PQC, the first steps are to try to pick the lowest hanging fruit so that you can really get people rallied around a common opportunity. And I think as these PQCs mature, they then start to really create the connection on the maternal and infant health side. And we're also really strongly encouraging that. Just like with any relationship in large organizations that, a statewide PQC, there may be some differences, but I think interestingly, the opioid crisis has been a real opportunity for groups to work together, and a lot of their efforts include both, opportunities to reduce opioid use disorder in pregnant women and also to reduce the consequences of MAOs. So I think you're seeing more collaboration and seeing a truly sort of perinatal quality improvement effort.
Other comments, questions? So David, you collected notes on all this?
Yes, I mean, we'll also get formal notes and transcription within a month.
So tomorrow morning we'll have a draft report?
Sure.
Okay. Thank you. So it does seem like if anybody has the brain power left tonight to do any more reading, we should try to read through what's behind these things and see what points that were brought up today may be in there and what are not, and what we want to modify, because we'll have time tomorrow to also work on some of these things.
Yeah, and just to be clear, it's in the briefing book link that was sent out, but it's also on the SACIM website, so you can get it either way.
What have we missed? Anything today? Magda? So far, I've agreed with everything you've just said. I think you're muted.
Now, for once, I muted myself. Good morning. I'm a little disciplined here in the late afternoon where you are. One other lens that I would encourage as people do some refreshment overnight, and that is there may one of the SACIM simple rules that Ed put out was to be pragmatic and in some ways to seize opportunities. Thank you for putting that slide up. And towards that end, I would encourage us to think hard about what are the immediate opportunities for recommendations that could be more short-term, that have an urgency or an opportunity to them now, either and whether it's a policy level or a data level, and now that particularly incorporating the broader lens of maternal health. I'm not going to push one out now, but I just think that if we come away from these 2 days still reframing and without grabbing onto some immediate concrete ideas and recommendations that could be helpful to the HRSA administrator and the secretary, and then we come into 6 months and we're on the phone, we lose that momentum that was expressed by most of the members as being important to sustain. Whether that has to do with the PREMIE Act, whether that has to do with immigrant women or incarcerated women, whether that has to do with supporting a particular research funding. I just think we should be prepared by the end of tomorrow to have identified what is hot that we might, 1, 2, 3 things that might be opportunistic now.
Maybe we should start in the morning with that if everyone wants to think about it tonight and come up with, a few. And we do it in a brainstorming mode. It does not have to be a Nobel Prize winning idea, just something to stimulate the thinking a little more. So
thank you for considering it.
Urgent, opportunistic ideas. It's also that time of an administration, too, where people are typically welcome short-term ideas but relatively quickly. Of course, there are no silver bullets, but there may be things that we can look at. So if people don't have other business, we are early. I hope that doesn't bother anybody. You can sit here and do email for a while if you'd like, but I'm feeling that perhaps we've gone for our agenda as far as we should go today. Anybody want to bring up a point before we do the summary? Anyone have priorities for tomorrow they want to make sure we get to? Malka just mentioned one. I feel like all you do too. So why don't, if you would, I really appreciate everybody filling in, and I think I appreciate your help in keeping this thing running relatively smoothly. And I know we all wish Ed the best. And there is a card here. If anyone hasn't signed it, we'd just like to sign it for Ed. And if I go pick up his suitcase, so I'll give it to him tonight.
And perhaps you could add the names of the people who aren't there. I trust you to do that, so it's the full committee.
Yes. That's true. All right, I'll send me a blank check with his signature on it, and I'll make sure I get your signature right. Okay. So how about if we just quickly go around the room and then the phone and sort of a one-sentence summary of something you took from the day. Would like to start?
I'll start here, and then we'll go down that way. Steve Calvin, I feel information overloaded, but really grateful for all the ideas. I've written like 5 pages of notes, so I'm looking forward to tomorrow.
So this is Paul. I'm excited about everything going on and about systematic things going on across the country, and including the development of the committee. So I feel energized.
Yeah, I'm very impressed with all of the talks. I'm impressed with all the information that I have. Same here. I feel like it's been a huge learning experience today. I think I'll be interested to see how all of these wonderful resources that we've identified, how we can maybe use, how they can work together. And we can coordinate that and to kind of, as we talked earlier about, have the biggest impact possible in the quickest amount of time.
This is Vijaya. When Wanda came in this morning, she mentioned that her son is going to college, first year in college, and we were talking about some of these issues before he was born. And so I'm excited for us to get to a point where we're acting on it and really making some progress. I hope I didn't age you and me.
First, I just wanted to thank everyone. This has been a wonderful meeting, and I appreciate the opportunity to just be a part of it. I'm just really encouraged by the direction that you have for action, for organic, plans, not waiting for the correct document or the final document or the best document, really taking your expertise, taking your role, and seeing the world and seeing what folks can do when they take it up and run with it.
Well, thank you for the opportunity to reflect a little bit, and I appreciate really the thoughtful approach to all of the data that's been presented and the committee members and how you're, I think, embracing the opportunity for action, and if we can help and support you in any way, I'm just happy to do that.
Hi, this is Lisa. I appreciate the opportunity to be here today also, and I really appreciated the presentations and
synthesis of the data and the information that's out there, and just sort of reflecting back on just a few years to see the progress that's been made and the systems that are being put in place and what we're starting to learn from that. And so I think then we've got more we can act on. So I just appreciate that progress that's being made.
Hi, this is Paul Wise. I've been struck by sort of an underlying contradiction. We've been talking a lot about remarkable innovations, technical innovation, and enormous technical capacity that has grown this field, but at the same time, historically, our ability to implement any of it is shrinking, not growing. And at some level, we're going to have to confront that contradiction if we're going to be successful.
Mm-hmm. This is Wendy from ACS. I just want to circle back around to something that was at the very beginning, and then I hope we keep it in mind and try to figure out how to address it with the 6 points, which is the rural issues that were identified. Pinning down what the research questions are, what the low-hanging fruit are there, or the, I mean, I feel like we're getting at the problems there. I didn't hear necessarily solution ideas or recommendations that would be made in that direction. Just want to keep rural communities on the table.
Hi, this is Belinda. I do think there's some wonderful work going on in our country, and similar to Vijay, I've been working on this issue in my own state for more years than I care to think about. And I don't want us to forget our Center on Equity. I think as we're thinking through the next steps and what we're actually recommending, that if we forget that, then we have forgotten our center. And I just want us to think through that tonight and tomorrow and as we continue to move forward.
I just want to thank the committee for, just the incredible thoughtfulness that it has come together today. It's been very exciting to see some of the progress in terms of how we're better understanding maternal health. And similar to what Vijay was saying, some of this was noted long ago. But I think one of the things that we're going to have to really think about carefully moving forward is how do we really embrace the needs and the health of women in a way that's, clear and distinct so that infants can benefit. And I think for a long time we've often looked at the baby, this cute, sweet entity, and really forgotten the adult here or the mom here. And I think we're going to have to really tackle that because there isn't always sort of as favorable a thought about maternal health and behaviors that may also contribute to adverse outcomes.
Hi, it's Danielle Ely. So for me, I get caught up with the data a lot, given my position in vital statistics. So for me today, it was very interesting to hear about the programs that are in place in different states or organizations in terms of improving maternal outcomes and how those outcomes are now being related to infant health, because I think, as we all well know, these dyads are very important in infant outcomes. And I think moving forward, keeping that in mind, and with other groups that have maternal and infant health initiatives going on, there may be some opportunities for us to work with them as well that may have more direct power in terms of maybe changing systems or influencing what kinds of opportunities are available for all or some women, depending on their insurance type or different things like that. So, thank you.
First of all, thank you for a really nice discussion, very thoughtful presentations, and for just your willingness to be here and have these discussions. I think that it's important to recognize that we have a unique opportunity right now where there's a great deal of public attention on these issues and political attention on these issues, and there seem to be some resources following that interest. And so it's it is an opportunity. We, at the federal level, sit on a lot of these committees and are involved in a lot of other non-FACA related work that seem to spring up out of everywhere when a topic becomes big and of interest to the general public. So I think I want to reflect back on one comment that was made from the one-on-one information gathering that Ed had done around vision, and that this committee take the time to really try to set its vision, and then to link that to a comment that I think Magda made it a little while ago about grabbing onto something that's immediate and having a win. Given the fact that you do have this opportunity, given the fact that Paul had said that we're at a specific point in an administration, you have the opportunity, I think, to set some vision and to show some accomplishments if you can sort of muster the will of the group, and really put yourself on a solid footing for the future. And I'd like to see that because you are one of, at the moment, many groups looking at some very similar issues. But given the fact that you are a federal advisory committee, it gives you a platform that some of the others don't. So please take advantage of that.
So I was going to say a lot of the same things about taking advantage of this being the first meeting after the new charter was approved that had the expanded focus on maternal health and maternal mortality. And strike now when there is big interest and lots of important people and lots of people are watching and looking for leadership and guidance. So just to build on what Lee said, you know, as I said this morning, my job is to make sure you all have what you need to do your job. So when you have whatever you want to do, whatever you want to move forward to the secretary or the administrator or even the associate administrator, Michelle, Julianne, and I will stand ready with lots of people behind us to help you all. But I think just remembering we only meet twice a year, I think let's not lose momentum and let's make sure that you do what you can do to get this in front of the people who can make decisions and make change.
She's just grateful.
Thank you. I wasn't really prepared to say anything. I thought I was in the peanut gallery. So I'm Lisa Satterfield. I'm from the American College of Obstetricians and Gynecologists. So we obviously are very excited for the work that this group is doing, and I'm here to provide any resources that you may need. I'm the Senior Director of Health Economics, and I've also been in conversations with the Centers for Medicare and Medicaid Services and others regarding this very important topic. So thank you for having this meeting.
Sorry. So yeah, I was part of this peanut gallery as well. My name is Iris Mabry Hernandez, and I'm the ex officio member for the Agency for Healthcare Research and Quality, pediatrician by training. Yes. And I also serve as a medical officer for the U.S. Preventive Services Task Force, which obviously has recommendations maternal and infant issues.
Well, tomorrow we won't let you sit over there. Phone, we want to, I guess we should probably call you. Magda, what do you want to go first? And
Be delighted. I want us to remember Tanya, our doula, who spoke with us at the first thing this morning about her work with incarcerated birthing people, and being at the separation visit at 36 hours as a reminder that there are sentinel events that go beyond maternal deaths, that we may want to have the courage to define, to augment, what we're doing in surveillance. And I would say that any woman who gives birth behind bars for a non-violent offense is an example of a social sentinel event. A woman who's pregnant and about to deliver being evicted from her home. That's a housing policy. So I just encourage us to be thinking about being inspired by Tanya to define some sentinel events that may be outside of our health sphere in terms of policy, and use those to change the narrative, to change policy, to change lives. That's what will inspire me overnight.
Thank you, Magda. There's a lot to think about there. Jean, do we still have you?
Yeah. I just want to say that I was most appreciative of listening to the CDC and March of Dimes information. I think looking at data and understanding where we've been and where we need to go and following some of the best examples that we've got in the United States, if we really are going to come about and effect change, we've got examples from around the world where we've got better outcomes, and within our own United States we've got examples where we've got better outcomes. So learning from those situations puts us ahead of the curve.
Thank you. Janelle? I have a mute button. Okay.
Hello?
Oh, yes, good. Please go ahead.
Okay, perfect. Thanks. I think it's an issue that I'm not always connected when I call in. So I am excited that we're going to be moving forward and giving specific recommendations, some tangible things to work on. I am Salish and Kootenai. I grew up on a reservation. Where I come from, children get pregnant when they're 15 years old. And this was my experience living on my home, where many of my friends became pregnant. And it wasn't always under the best of circumstances, as you can imagine. And it was because of what I saw within my family and within my community that I wanted to do something about it. I was the first to go to school, to higher education in my family. And I became a midwife, and I got a PhD, and I started doing research with tribal communities. And I'm so thankful that I am now coming nearly full circle in being able to actually be with a group of people who can make recommendations for things to happen. So I'm very excited for the upcoming moments that are going to be happening tomorrow. I do want to let you know that I am also working at the hospital, so I will be trying to call in while I am on shift. And in the meantime, I will send my thoughts for recommendations by email to the group.
There actually is a full moon tomorrow. So, Cheryl?
Hi. Yeah, I don't have anything terribly original to add, but I will just echo the thanks to today's presenters for their enlightening talks, particularly from Becky and Charlene. Thanks.
Thank you. Can I have Dorothy? And then I can't read. I'm sorry. Tiffany? It's our nurse. To read my notes. Okay. Well, thank you all very much for today and all the thought. And like me, my head's kind of swirling. We're going to have to take some time to really incorporate this and decide where to go with it. But it's so incredibly stimulating, and it's so wonderful to be here with such knowledgeable and smart people. So thank you. And David, do you want to tell us about?
Yeah, so you can leave your stuff here tonight. I wouldn't leave laptops or anything of too much value, but you can leave other stuff here. We'll be in the same room tomorrow. We'll start right at 9 o'clock. We should have at least 2 more community folks speaking to us. We rescheduled one of them. We hope we're rescheduling one of them, and then we have another one that was already scheduled for tomorrow. One of the things that we will have to do before we adjourn tomorrow is to approve the April minutes. So those are also in the briefing book. I did get comments from a couple people, Dr. Hogan and you in particular, But if anyone else has any comments, we feel like they're in good shape. There just may be some small things we need to correct. So just let us know, and then we can approve them tomorrow and make those final and move those forward. Otherwise, unless there's anything else for the good of the group. Okay, have a good evening, everyone.
Thank you.
Thank you.
Thank you all for participating in today's conference. You may disconnect your line and have a great day or a great evening.